Court is in session. Please be seated.
May I proceed, Your Honor?
Yes, please.
Your Honor, before the court today, we have the matter of Commonwealth versus Lindsay Clancy. Ms. Clancy is present. She is represented by Attorney Kevin Reddington. The Commonwealth is represented by Assistant District Attorney Jennifer Sprague and Assistant District Attorney Shannon Buckingham.
All right. Good morning, counsel.
Morning.
All right. Good morning, Ms. Clancy. Counsel, can I just see you briefly just for a second, and then I think we'll be ready to bring the jury in.
All right, jurors entering.
And you shall be heard. God save the Commonwealth of Massachusetts. This court is now in session. Please be seated.
Good morning, Your Honor. May I proceed?
Yes, please.
Your Honor, before the court today, we have the continuation of the jury trial in the matter of Commonwealth versus Lindsay Clancy. Ms. Clancy is present. She is represented by Attorney Kevin Reddington. The Commonwealth is represented by Assistant District Attorney Jennifer Sprague and Assistant District Attorney Shannon Buckingham.
All right. Thank you, Madam Clerk.
Welcome.
Well, good morning, everyone. I hope everybody had a restful weekend. So what I want to do is just kind of tell you, first I'm going to go through those questions, make sure everybody was able to follow my instructions. Then I'm going to go over what today's schedule is, and then we'll return to the Commonwealth's presentation of evidence. All right, and so let me ask those questions. First question, has any member of the jury read, seen, or overheard anything from any source about any aspect of this case that would affect your ability to be fair and impartial? All right. Next question. Is there any other serious matter or concern bearing on your service as a juror in this case that anybody needs to bring to my attention? All right, again, thank you for following those instructions. Now, today's schedule, let me say first thing about the schedule. I know I haven't always been completely correct on some of the schedules we followed, but I want to just let you know that those decisions about the scheduling is on me. All right, and sometimes I have to take into consideration other factors or things that are going on. So what I really wanted to tell you is that don't speculate why we might go a little late or a little early on any certain days, but certainly don't hold it against either side in regards to that. The person who's making those decisions or that decision is me. All right, so you should be aware of that. So that being said, the thought is today we should go into the afternoon. All right, and if that changes, I'll let you know. And what we're going to do at this point, we're going to return to the Commonwealth's case. And with that, Commonwealth, call your next witness, please.
Your Honor, the Commonwealth will call Michael Snyder.
While we're waiting for Dr. Snyder, could we just approach?
Oh, sure, yeah.
Thank you. Apologize.
Good morning. Do you solemnly swear that the testimony and the evidence that you shall give to the court and the jury will have an outcome between the Commonwealth and the defendant about you? Thank you. You may have a seat, sir.
Watch your step, please.
All right, good morning, Doctor.
Good morning.
All right.
May I inquire?
Attorney Buckingham, please.
Thank you. Good morning, sir. Could you please tell the jurors your first and last name?
Yep, Michael Snyder,
Do you mind spelling your last name for the record, please?
Snyder.
And how are you employed?
A physician at Beth Israel
And how long have you been a physician?
since 1998.
Can you tell us a little bit about your educational background?
So undergrad at UMass Amherst, I did medical school at Tufts University, and then I did my residency in emergency medicine at Boston University.
And how long have you worked at Beth Israel?
Since 2014, 12 years.
And do you primarily work in the emergency department?
Yes.
I'm going to draw your attention to January 24th of the year 2023. Do you recall working in the emergency department on that day?
Yes.
And in the evening, were you made aware of multiple pediatric traumas that were coming into the emergency department?
Yes.
And when you are made aware of people coming in, how does that occur?
So we'll typically get a call on the EMS phone that something's coming in that they want us to know about up front.
And do they provide you with some basic background information about what's occurring or what occurred on scene and what's occurring during the transport?
When possible, yeah.
Okay. And when the emergency personnel, the EMTs or paramedics, arrived at Beth Israel, there were 3 patients, correct?
Correct.
And you were assigned to treat 1 patient?
Correct.
Do you recall which patient that was?
Cora?
And prior to EMS arriving, did you learn more about Cora's presentation and what was occurring?
Yeah, so we had heard that, all 3 were in cardiac arrest, and Cora in particular, they were still working on doing CPR and doing what we call pediatric advanced life support, so medications to try and restart the heart. And they also mentioned that they had used what we call a defibrillator to shock the heart to try to restart it, and they were still doing CPR when they were arriving.
And is this information important to you as you're assessing a patient coming into the emergency department?
Yeah, it's important to know, what things look like in the field, how long the patient might have been without a pulse, or how long they may not have been breathing for, so we can kind of expect or know what injuries to look out for, what we can potentially reverse.
And were you aware of the age of Cora?
Yes.
And she was 5, correct?
Yes.
And as far as the medications that you were aware of, what medications had been provided?
So prior to coming to us, she had been given epinephrine, which is the primary medication we use in a cardiac arrest.
And do you know how they had administered that medicine to her?
Yeah, so she had what we call an intraosseous device in her right tibia. Sometimes it's very difficult to get an IV in, so we can go directly into the bone or the bone marrow.
And were you aware of whether she had been intubated en route?
So she was not intubated en route.
When she arrived at the emergency department, were you there to greet the ambulance?
Yes.
And what happens when a patient comes in through the emergency department via ambulance?
So when the patient first comes in, we immediately have our team, start to sort of take over care so there's no gap. And then we also get a sign out from the paramedics and EMTs and any other staff that had been involved in the case.
And do you and your emergency room staff then perform your own initial assessment of the patient?
Yes.
So what do you do for that?
So initially we sort of go through our ABCs, airway, breathing, circulation. So initially, focusing on the primary things such as making sure we're getting air and oxygen into the patient, keeping the heart going, so continuing CPR at that point.
And as far as Cora went, did you observe that she was breathing?
So she was not breathing on her own.
How about the heart? Did you observe that her heart was beating?
There was no heartbeat.
How about her physical appearance? What observations did you make of her physical appearance?
So initially when she had come in, some of the things we notice is sort of a blue tint to the skin, which typically, we can see when there's less oxygen or lack of oxygen. And then the other things on a quick survey is there was some areas of bruising on the neck and around the eyes, called petechiae, kind of little bleeding, episodes of bleeding under the skin, and I believe a small amount of blood coming from the nose.
Were you able to make observations of her hands or other parts of her body?
So the hands definitely had that, what we call cyanosis or blue hue.
Now, as far as the eyes, you mentioned petechiae around the face and the eyes as well as the neck. Did you notice anything else about her eyes?
So the pupils were fixed and enlarged.
Why is that significant to you?
So oftentimes when we see it coming in, it can indicate 2 different things. Some of the medications like epinephrine can cause the pupils to dilate, but also if the brain is starting to become damaged or not functioning, then you start to lose initially some of the signals that would make the pupils smaller, so they'll tend to start to get enlarged or dilated if there's brain injury starting or has occurred.
Now, you indicated that when Cora arrived, she was not intubated, meaning she did not have a breathing tube in. Did you and your team attempt to intubate her?
Yes.
And did you do that on your own or with the assistance of other parts of the emergency department or the hospital?
So we had anesthesia there. After we got the phone calls of multiple patients coming in, typically we'll have all the help that we could possibly need there to be able to take care of all the patients. So I had an anesthesiologist in the room with me who put the breathing tube in.
In instances where an individual might have suffered some sort of injury to their neck, does that complicate the insertion of a breathing tube?
It can, yeah, because normally you might need to move or tilt the head to get a direct view where you can put a breathing tube in. But when there's a concern for neck injury, we stabilize it typically with a collar or manually. So you don't have the ability to move the head and the neck around to try and get a better view.
Once a breathing tube was put in, were you and your team able to manually give breath to Cora?
Yes.
Now, did you then perform an assessment, a cardiac assessment of her?
Yeah, so in addition to listening to the heart, feeling for a pulse, we'll also tend to use an ultrasound machine in the room where we can kind of get a direct view of heart function. And
you were aware that they had defibrillated her twice in the ambulance. Why is that significant when you're treating a patient that's in cardiac arrest?
So when they defibrillate a patient, it's typically the heart's or might be in a rhythm where it can't pump blood, so it might be sort of out of sync or quivering, where we may attempt to use electricity to kind of shock it back into a rhythm.
Once you performed the ultrasound, the cardiac ultrasound, were there any attempts made further to use a defibrillator or?
No.
Throughout your course of treatment with her, did you continue with various medications?
Yes.
And was CPR ongoing throughout your entire time with her?
Yes.
Were you consulting with any other colleagues or any other hospitals in regards to the care of Cora? Yeah,
so we actually had, in addition to all my colleagues in the emergency room, we had intensive care physicians from Children's that were on the phone with us, kind of working through any things that may have come up in the case, also expecting that they would be receiving the patients from us.
Is your hospital at the Beth Israel equipped to handle this type of pediatric trauma?
So we can do the initial stabilization, but then we need to ship the patients out to either get a specialty care or continued inpatient care.
And how long did efforts in treating Cora continue?
So in the emergency room, roughly 30 minutes.
And fair to say that all of the efforts that you made were not successful?
Correct.
And at approximately 1928 or 7:28, did you finally declare Cora deceased?
Yes.
Thank you. I have nothing further.
Anything?
I have no questions. Thank you, Doctor.
Thank you,
Thanks.
Doctor.
Thanks.
Commonwealth calls Dr. Andrew Capraro.
All right, good morning, Doctor.
Morning.
If I may?
Yes, please.
Thank you. Good morning. Can you please state and spell your name for the record?
My name's Dr. Andrew Capraro, last name Capraro.
And your date of birth, please?
July 9th, 1970.
What do you do for a living?
I'm an attending physician in the emergency department at Boston Children's Hospital.
And how long have you done that?
For the last 26 years.
Can you just briefly describe for us the training and education you had to qualify for that role?
I went to Providence College undergrad and then went to Brown Medical School. Subsequently, I went to Connecticut Children's Medical Center for my pediatric residency and then did fellowship training in pediatric emergency medicine at Boston Children's Hospital from 2000 to 2003 and have been an attending there ever since.
And what's involved with being an attending at Boston Children's Hospital?
It means that I am guiding the care and treatment for the patients that I am seeing during my particular shift.
And are you assigned to a specific location or area of the hospital?
I'm always in the emergency department, and the emergency department is broken up into different zones, of which I am sort of the primary attending for one set of rooms.
I want to direct your attention to January 24th, 2023. Were you working that evening?
I was.
And at some point in time, did you learn that a patient named Callan Clancy was going to be transported to your hospital?
I did.
And do you recall where he was being brought from?
From Beth Israel, Plymouth, I believe.
And was he being med-flighted to your facility?
Correct.
And were you provided with some information about the patient in order to prepare for his arrival?
I was.
And what did you learn?
We have a communication center where facilities that are transferring patients to us call to let us know that the patient is coming. And so that comm center had been notified about this patient, who then got in touch with me as the attending who would be caring for the patient. To let me know what had happened there and the condition of the patient when he was arriving.
And what did you learn about the condition of the patient, Callan Clancy, as he was being flown to your hospital?
What I was told was that it was believed that the patient had been strangled, and when he arrived at Plymouth, he was in cardiac arrest, that they had intubated him and initiated CPR, and they had gotten return of spontaneous circulation, and that they were then going to transfer him to us for further evaluation and care.
And at some point in time, did Callan arrive at your hospital?
That is correct.
And were you able to observe him physically?
Yes.
What observations did you make about his physical condition?
He was cold on arrival, and he was quite limp, was not making any purposeful movements on his own. His pupils were fixed and dilated, and he had ligature marks about his neck with some swelling of the neck.
And his pupils being fixed and dilated, is that medically significant for you?
Yes, it is.
And why is that?
It typically means that significant injury has happened to the brain, such that there is brain swelling that has sort of it has overwhelmed the capacity of the skull, such that the swelling has made the brain sort of herniate through the base of the skull.
Does that mean the brain's swelling so much it's pushing through the skull?
Correct.
And what observations did you make of his heart rate?
His heart was beating, and we did have to provide him with an epinephrine drip to keep his heart rate and his blood pressure within normal limits, but it was beating on its own.
And how did you know that you had to provide the epinephrine for him to stabilize that heart rate?
It was initiated at BI because they had noticed that his blood pressure was low, and you need to have normal blood pressure for the blood to perfuse your organs and keep them healthy. And so we were looking for certain parameters to sort of maintain that, which we did on that epinephrine drip.
And when you say BI, you're referring to Beth Israel?
Yes, I'm sorry about that.
That's okay. And so as far as his breathing, how was he breathing on his own?
He had been intubated at the outside hospital, and he was needing a ventilator to breathe for him. Occasionally, he would have sort of a breath on his own, we would notice. We were able to see that because when he attempted to take a breath on his own, he would trigger the ventilator to continue that breath. But it was rare. For sure, he needed the ventilator to maintain his ventilation.
Would it be fair to say that the majority of his breathing was being done by the ventilator?
Yes, the vast majority of his breathing.
Now, once you have received this information while he's coming in, and then you've made your own physical observations of Callan, are there certain tests that you have run on him?
Yeah, our job, once we received him, was to perform further evaluation and stabilization to help determine what the next steps of his medical care would be. So prior to him arriving, we had contacted our trauma team and our ICU doctors to let them know that he was coming and that we would need their assistance. And then under my care, we performed some routine blood work, so a head CT, a neck CT, and a chest X-ray to sort of help us guide the next steps.
And from the head CT and the other testing that you did, what were you able to learn from the results of those tests?
The head CT in particular showed significant brain swelling consistent with hypoxic ischemic injury, which was which was the most significant finding that we found.
So could you please explain for us what is hypoxic ischemic injury?
Hypoxic is just a fancy word for not getting enough oxygen, and ischemic is just a fancy word for not getting enough blood flow. And so when your organs don't get enough oxygen and blood, they sort of suffer injury and therefore get to swelling. And so his brain was showing evidence of that.
So would it be fair to say that his brain wasn't getting enough oxygen and blood flow, and then because of that it was damaged and swelling?
Correct.
Now, this type of swelling and injury, as you're describing it, can that be caused by strangulation, the injury of the brain?
Most certainly.
And you mentioned earlier that you did see some marks around his neck. Is that correct?
Correct.
And what were those consistent with?
Strangulation of some sort, most likely from an object, based upon the linear aspect of the bruising.
And when you say the linear aspect of the bruising, does that mean it's in a straight line?
Correct.
Now, once you had the results of this testing, was there, did you make a decision on what to do next?
Yeah, the main thing was to help us figure out, did the patient need to go to the operating room for some sort of other procedure to help with this, or was this something that could be dealt with medically? And so once we had the results of the head CT and then the neck CT as well, it was felt that the next appropriate step in his medical care would be to be transitioned to the intensive care unit for them to take over care.
Why was it that surgery was not an option to help Callan in this situation?
Yeah, the neurosurgery doctors were there to sort of help us make that decision. There was no significant bleeding, for example, that would need to be evacuated. There was nothing that they felt from a surgical point of view would help alleviate the problems that we saw in the CT.
Okay. And so was his care transferred to the ICU?
That is correct.
And once Callan was transferred to the intensive care unit, did your care for him end at that point?
Correct.
I have nothing further. Thank you.
Thank you. Mr. Reddington?
No questions. Thank you, Doctor.
Thank you, Doctor. Please step down. Thank you.
Commonwealth calls Dr. David Casavant.
All right, good morning, Doctor.
Good morning. Morning, Honor.
Attorney Sprague.
Thank you. Good morning. Can you please state and spell your name for the record?
Surely. My first name is David. My last name is Casavant. It's spelled C-A-S-A-V-A-N-T.
And your date of birth, sir?
5263.
What do you do for a living?
I'm an ICU physician at Boston Children's Hospital.
Can you briefly describe for us your educational and training background?
Sure. I went to college out at Holy Cross in Worcester and then to medical school at Boston University. I did my initial pediatric residency at Mass General Hospital and then went back and did a fellowship in ICU medicine at that hospital as well.
And where do you currently work?
I currently work at Boston Children's Hospital in the medical surgical ICU.
And how long have you worked at Boston Children's Hospital?
18 years.
And have you always worked in the ICU there?
Yes.
I want to direct your attention to January 26, 2023. At that point in time, did you take over the care of a patient named Callan Clancy?
I did.
And prior to taking over the care of Callan Clancy, did you do anything to familiarize yourself with his treatment and care?
Yes, I did. One of my colleagues had taken care of him the day before in the ICU, and I spoke with her, and so I was familiar with his case.
Okay. And did you also review reports and testing that had been performed while he was at the hospital?
Yes, I did.
Okay. And after reviewing the reports and the test results and speaking to your colleague, can you tell us what you learned from all of that?
Well, it seemed that Callan had a severe neurologic injury based on both testing and the examination that I did at the time.
And when you say a neurologic injury, is that a brain injury?
It's a brain injury, yes it is, yeah.
And did you review specifically a head CT scan of Callan?
Yes, I did.
And what did the head CT scan show you or tell you about his condition?
Well, the head CT is a picture of the brain, which was done in the emergency room when he was admitted to Boston Children's Hospital. And the CT scan showed an enormous amount of swelling of the brain itself.
And that the swelling of the brain, is that medically significant?
Very much so. When you have an injury to the brain that is caused by anoxia, which means a lack of oxygen, I describe this with families that the injury is very much like being out in the sun. You don't notice it at the time, but swelling occurs over the course of time. And one of the things with a lack of oxygen to the brain is the injury occurs and then swelling starts to happen over the course of time, typically peaking at 48 to 72 hours. When you see swelling that happens that early in a case, as in Callan's, it means that there's been a very significant lack of oxygen and therefore injury to the brain itself.
So, for example, some types of injuries that would withhold oxygen from the brain would be more mild and the swelling would occur over time. Is that correct?
That's exactly correct, yes.
So if a severe injury happens that withholds oxygen from the brain, that's when you see that immediate swelling like Callan had?
Very much so. Sort of the comparison of a sunburn to a burn that you might get from a stove. This was a stove. It's very, very profound.
Did you perform a physical examination of Callan?
I did.
And what did you observe?
Well, one of the first things that I noticed as I approached him was that he had a breathing tube in place, and I knew from my colleague that he was not on any sedation, which is very difficult to tolerate, having a breathing tube through the vocal cords if you're not sedated, and he was not sedated at the time. The next thing is that when I approach a patient in their bed in the ICU, we always start with a quick introduction that we're going to be coming near them in case they're asleep. And I usually start with something along the lines of, I'm Dr. Dave, I'm just going to listen to your heart. And I'd usually address them by name and to see if they start to respond. And then I'll go ahead with the rest of the exam, but that's just to sort of warn them that someone might be touching them. And then I'll listen to heart, lungs, and then to move forward to see if how responsive they are. So if you get no response at all from the initial, just using your voice, the next thing is and then from the exam, if they don't move around, then you start to sort of think, well, let's see how responsive they are. And so the next thing is sort of a gentle touch off into the bottom of the foot to see you stroke the bottom of the foot and you see if they pull away. And then you can move. If you get no response from that, we'll do something that's a little bit more noxious or painful, where you can sort of pinch a little bit of skin to see if they start to react, or pushing on the fingernail and the nail bed pressure, which is actually very noxious. And if you can see two types or several types of response, either no response, or you can see a very specific response where they pull away from that area, and that's a specific, or you can see generalized response, which are all sort of graded along those that are as we're sort of getting a sense for what their level of consciousness was.
So if I could go over a few of those things that you just mentioned. You said that that the first thing that you noticed that was significant was that Callan had the breathing tube in place through the vocal cords without any sedation. So without sedation, would having a breathing tube in that place cause pain?
Yes. No one would be able to tolerate it.
And so Callan was able to tolerate it without any sedation.
Yes.
Would that indicate he wasn't feeling that pain at that time?
Yes, exactly.
And you mentioned that you would address the patient by name and talk to them. Was there any reaction from Callan when you did that?
No, there was not.
And then you mentioned you would rub maybe something along the foot. Was there any reaction?
No, there was not.
And did you do what you described in pinching the fingernail or pinching somewhere on Callan to see if he responded?
Yes.
And did he respond?
No, he did not.
And what did these interactions and tests on Callan tell you about his condition?
This told me that he was unresponsive. He was unresponsive to both things that would cause discomfort and things that would cause pain.
Did you also do anything in terms of looking at his pupils and any tests on his eyes?
Yes. So after all the other things, that we look at the pupils, and so one of the things is we have it's a reflex response. If a light is shown in an eye, the pupil constricts. And what I noted about Callan was that his pupils stayed widely open and did not constrict.
And when someone's pupils stay open and wide when you shine a light in them, what does that indicate medically?
Well, the eyes are a direct extension of the brain, so that's why we focus a lot on them as an area of investigation. And the lack of a response to light indicates that there's some abnormality to that, and in this case, it was a brain injury. There's medications that can keep your eyes open if you've ever had an eye exam, but that was not the case with Callan.
And just to be clear, when you're talking about brain injury, we're not talking about some type of trauma that was inflicted on the brain. You're talking about the lack of oxygen and blood flow causing an injury to the brain, correct?
That's exactly correct, yes.
At that point in time, did you work with another doctor to do more in-depth testing regarding his neurological status?
Yes. So at Children's, we have multiple teams that come together for a patient, for many patients. But for Callan, the neurology team was there from the beginning. And when in a case like this, when we see no response in an unresponsive patient, we start to get our neurology team, and one of the things we start to do is brain death testing to see if they could be what we call brain dead, meaning that the brain itself is not functioning, and that even though their heart is still beating.
How is it that someone's heart can be beating if their brain is dead?
It's a really good question. So there's actually two parts to the nervous system. The one is the part that we see the most in people when they react, and they react to us and they speak and they do things. The other one is the autonomic or automatic system. And the automatic system is largely in charge of the things like the heart, if the heart has not been injured. And so it was sort of continuing on.
And does that give you any indication, the fact that the heart was still continuing on, about where the injuries were in the brain?
Yes, it does actually. Yeah,
Where would that be?
Yeah, so the large part of the brain that we sort of think of as when we see the pictures of the brain, that's the cerebellum, and that's the biggest thing in humans that is most developed, and that's in charge of our consciousness, our reaction to things, whereas the brain stem, which is another part, and that's really part of the autonomic system, and that's the same in almost all vertebrates and mammals, and it's much more automatic, and so it tells me that it seemed the cerebellum, which is that part that makes us sort of the human side of what we do, that's much more sensitive to a lack of oxygen, to an anoxic injury. And it told me that was really where that injury was in that part of the brain, much less so in the brain stem itself.
So would it be fair to say that the brain stem itself that controls those automatic responses was still functioning somewhat, but the part of the brain that made Callan was not functioning?
That's exactly correct, yeah.
And can you describe for us the brain death testing?
Sure. So the brain death testing at Boston Children's it's a very strict testing that includes some of the things that I just mentioned, but we work with our there's a checklist that we work on with our neurologic colleagues. And we sort of go through each of what we would expect for responses from someone, and we actually then work through different of the nerve sets that we would expect them to respond to. We have it set up so that there's an ICU physician is there, and then a neurologist is there, and the neurologist and the neurology team, they're the ones who perform the brain death testing. And then the test is then repeated again 24 hours later, just to make sure that there's no piece of that is different or incongruous with a diagnosis of brain death.
And while the neurologist is doing this testing, are you there present, watching the testing and seeing the results as it happens?
Absolutely, yeah. So we're sort of committed to being there for the whole time. And the brain death testing itself goes through some really basic things. Again, as I described earlier, the things that would be painful and do they pull away or not. The eyes, looking at the reflexes of the eyes. There's also other reflexes too. Things like if you stroke the cornea, which is the front of the eye, people blink, and that's so the blink reflex, cough, gag. There's also a reflex where they actually put cold water into an ear, and that gives people a disequilibrium. And so those are all the things that we think about. And then also too, there's some breathing components to that as well.
Is one of those breathing components an apnea test?
Yes, it is. Yeah.
And what is an apnea test?
So apnea is a word that just describes describes a lack of breathing.
And how do you test that?
So in a patient such as Callan, what we do, and in any patient when we're doing brain death testing, we actually disconnect them from the ventilator. And the reason that we do that is we want to see if that autonomic system in the brain will start to react as the carbon dioxide starts to increase. So our body makes carbon dioxide all the time, and the way we get rid of it is by exhaling. And where we breathe in fresh oxygen, and then we breathe out CO2. And what we do is we disconnect from the ventilator to see if, knowing that their carbon dioxide will start to rise, and the normal response for that autonomic part of the brain would be to sort of increase breathing. That's why we breathe when we sleep, because as we go to sleep, the conscious part of our brain stops, but the autonomic part kicks in, and then we breathe right through our sleep because that carbon dioxide rises.
So in a patient who has brain death, would it be accurate to state that as the carbon dioxide level increases, the automatic response would be to take a breath to get more oxygen, but a patient who's brain dead won't do that?
That's correct.
And did you do all of these tests, or did the neurologist do all these tests on Callan while you observed?
Yes, they did, yeah.
And did he have any response to any of the physical tests where you were looking for a reflex or a reaction?
No, he did not. No response to any.
And what was his reaction or results on the apnea test?
So the apnea test, again, we do all the brain testing one day, and then we wait at least 24 hours for the second one. The first, and what we expect with the carbon dioxide is that it will increase. We have it written in our, so it's all in writing for our protocol, that it will increase by 20 or get to a level of 60. A normal CO2 would be around 40. And the first time we did that, on the first day, it actually went to 59.7, not 60. And again, it was in our protocol as it has to get to 60 or increase by 20. And I actually talked to my colleagues, including neurology. I said, I know this is very close. It's 59.7, but it's not 60. I repeated that piece of the test later on that day to make sure that it was valid. And as I say, I checked with everyone to make sure that I was doing the right thing. They all agreed that we should just, and the second time it went to 87. So that was, everything else was the same. And we made sure that things that we look at too to make sure that there's not on any medications, that there's no changes in his temperature, there's no abnormalities of the salts in the blood, what we call the electrolytes. So all those conditions were the exact same. And I repeated that later on in the day, and it did come back positive.
Why is it so important that you meet that specific criteria? Why is 0.3 of a point so important?
Well, I wanted to make sure that there was no question about the data that we were gathering at the time.
And you said that this testing is again repeated 24 hours later, correct?
Yes, it is.
Why is that?
Well, that's just to make sure that if there were any lingering effects of medications, if there was anything that else might have changed in the patient's level of alertness or level of response, to make sure that it still meets all those requirements 24 hours later.
And is it because you want to be sure that there's brain death before you remove life support?
Yes, and again, it's too important. It's too important a discussion and a gathering of data to not be very exact about it.
And so, when you did observe the testing and the following day on Callan, were the results the same in terms of no reaction and the carbon dioxide increasing?
Yes, they were.
And at that point in time, did he meet brain death criteria?
He did. He met. So we had determined that it was that he had met death by neurologic criteria.
And at that point in time, was a decision made to stop life support?
Yes, it was.
And that's done in consultation with the family, his father, correct?
Yes, that's true.
Okay. And was life support ended for Callan Clancy on January 27th, 2023?
It was, and one of the things is there's when you determine that someone has met criteria for neurologic brain death, that although we know that their brain is not functioning at that point, there's often a period of time where we don't have to his heart is still beating, so we don't have to remove the endotracheal tube at that time, and we often will give families, once it's been confirmed that the brain is no longer functioning, we often give families a period of time to able to process it, and a window of time. Sometimes there's relatives who will need to travel and things like that, and so we'll often then choose a time later on to accommodate the rest of life, knowing that they're stable at the time, to when we would actually remove the tube, and that would be the declaration of death.
And was that done in this case? Family was given an opportunity to see him, and then life support was ended, and then his heart stopped?
Yes, that's exactly.
He was declared deceased?
Yes.
Thank you.
Attorney Reddington? Thank you, sir. Thank you, Doctor.
Thank you so much.
Your Honor, at this time, the Commonwealth would move to admit the Boston Children's Hospital records for Callan Clancy into evidence. There's 2 volumes.
Objection.
Your Honor, I have no objection because we both have the records. We both want them in evidence, so I have no objection to any of the records that they have. We signed releases for them, for like Beth Israel, Brigham and Women's, South Shore. They all can go in.
That's a yes.
It may be admitted.
Exhibit 137.
Yeah, I went to A and B. Yeah.
137 A and B.
All right, thank you.
Commonwealth would call Kelly McDonough as state's witness.
I'm sorry, if you say the name again?
Kelly McDonough.
Okay, sure. Hey, good morning.
Good morning.
May I inquire? Thank you.
Yes, please.
Good morning. Could you please tell the jurors your first and last name?
Kelly McDonough.
Can you spell your last name for the record?
McDonough.
And what do you do for a living?
I'm an emergency medicine physician.
And how long have you been a physician?
11 years.
Can you tell us a little bit about your educational background?
I went to medical school at the University of New England in Maine. I did my residency at Kent Hospital in Rhode Island. I subsequently worked at Kearney Hospital in Dorchester, and I've been at South Shore Hospital since 2021.
And in what, are you primarily in the emergency department at South Shore Hospital?
Correct.
Have you been in any other department at South Shore Hospital?
No.
Are you licensed to practice in Massachusetts?
Yes.
I'm going to draw your attention to January 24th of 2023. Were you working in the emergency department that evening?
I was.
At some point, were you advised that a patient was being brought into your emergency department?
I was.
And were you aware of that patient being Lindsay Clancy with a date of birth of 8/11/90?
Yes.
And what kind of information were you given upon learning that the patient was coming here? What were you expecting to receive?
I was expecting a trauma 1 response, a patient who had fallen out of a window from a height and didn't know much more than that.
Okay, and so when you say trauma 1, what does that mean for you?
So we have 2 designations for trauma responses, a trauma 1 and a trauma 2, and there's certain criteria for each. And there's a long list of criteria that are determined by the resource nurse who receives the EMS call.
Okay, and so when we say 1 and 2, which is more serious than the other?
Trauma 1.
Okay. And so what do you do to prepare when a patient is coming in and you know coming in that it's likely a trauma 1 situation?
So we gather in the trauma room and make sure that we have all available staff needed to take care of the patient.
And what kind of staff are with you in the room, in the trauma room?
So for a trauma 1 response, it would be the emergency medicine physician, it would be anesthesia, the trauma surgeons, sometimes neurosurgery will be there.
And fair to say you also have a whole host of other staff, including nurses, emergency room techs, all of those people are also available to assist if you need it.
Correct.
Now, when this individual came in, when Lindsay Clancy came into the emergency department, were you aware from EMS that she had already come in with some sort of neurological deficits?
I think that from my best recollection, we knew that she was unresponsive, found down outside of her home.
Were you advised that it appeared she might have a spinal injury?
Yes.
And that she was not she may have been moving her arms and her head, but not her legs?
Correct.
Now, when the team was assessing her in the emergency department, what types of steps do you take to perform that assessment of the patient?
So there's a series of steps that we go through to assess a trauma patient that are followed every single time. ABCs, airway, breathing, circulation, and then we do a secondary survey.
Okay. And in this circumstance, was the patient breathing?
Yes.
And when she came into the emergency department, was she breathing on her own or intubated?
She's breathing on her own.
At some point, did the ER staff have to intubate her?
Yes.
And why was that?
For airway protection, there was a concern that maybe she would have a head injury and she would decompensate later. And so to protect her airway, she was intubated.
Now, is that a standard protocol when there's concern for head injury?
Yes.
Did you see any obvious signs of a head injury when she arrived into the emergency department?
No.
What kinds of things would you see if somebody had an obvious head injury?
You might see bleeding or lacerations or abrasions.
Now, did you observe any other obvious injuries to this patient?
I did. She had some superficial lacerations of her neck and wrists bilaterally.
Do you recall if she came in on a backboard with a C-collar?
She did.
And do you remove the C-collar at some point to assess the patient for injuries?
We didn't completely remove it temporarily to visualize and feel her neck and then put it right back on.
Okay, and you said you did observe some injuries to her neck, correct?
Yes.
I'm just going to show you some photos that have been already marked, if that's okay, on the screen next to you. this has been marked as exhibit number 111. Is that an accurate representation of the neck injuries you observed?
Yes.
You also indicated that she had some other injuries to her wrists.
Yes.
And I'm just going to show you 112. Is that accurate as to the injuries to the wrist you observed?
Yes.
Now, you described the injuries as superficial. The injury that's kind of in the middle of the photograph there, can you describe what part of the body that injury is?
You're describing the one that's sort of open?
Yes.
Yeah, so that's the anterior aspect of her wrist.
And were you able to examine that injury?
Not in detail.
Okay. Was it something in your emergency, your assessment of the trauma 1 situation, was that something acute that you had to address?
No.
And is it fair to say that that injury goes through kind of the subcutaneous tissue of the skin?
Yes.
Did you observe any injuries to an artery or a vein or anything in that area?
I did not.
And then just showing you Exhibit 113, which is the other wrist. Same thing. Did you observe anything in your assessment, your trauma 1 assessments, to say whether these were acute at the time?
I assume that they're acute.
Okay, but as far as treatment of them, did they require you to immediately address it
No.
or manage blood flow?
Mm-mm. No.
What was the more serious, or what was the focus of your assessment of her in the emergency department?
I think the main concern was for a head injury and or a spinal cord injury.
And you said that as part of the assessment team, you had a neurosurgeon available as well as a trauma surgeon, correct?
There was no neurosurgeon there that day.
Okay. Was there a trauma surgeon?
There was.
Who was that?
Dr. Christina Carpio.
Did you order any series of tests in order to help you assess the nature of whether there was any head injury or what the extent of the spinal injury could have been?
Yes.
What kinds of tests did you order?
CAT scans.
As part of the emergency room protocol, do you also draw blood for patients that come in?
Yes.
And how is that usually done?
It's usually done on arrival by the nursing staff.
And do they draw blood according to a physician's orders, or do they draw blood for various purposes? Explain to us how that works.
Mm-hmm. So it's usually like what we call a rainbow. So they just draw all the tubes of blood as soon as the patient arrives in anticipation for orders.
Okay. And so what happens to the blood after somebody in the emergency department takes it from the patient? Where does it go?
It gets tubed to the lab.
And fair to say that at Sejal Shah Hospital they have a pneumatic tube system, correct?
Correct.
And that it goes to a separate laboratory.
Correct.
And once a physician then assesses a patient and determines what kinds of testing needs to be done on those samples, how do you communicate that to the laboratory?
So orders are put into a computer and they go through the computer to the lab.
And as you're treating a patient, is it oftentimes necessary to change the orders or order additional tests?
Yes.
And so in this particular case, blood and urine was collected from Lindsay Clancy upon her arrival, correct?
Correct.
And then sent to the lab?
Yes.
Okay. Now, going back to the imaging tests, you said that there were some CT scans that were ordered?
Correct.
What areas of the body were the CT scans for?
It was her entire body, her head, her neck, her chest, her abdomen, and her pelvis.
Now, as far as the CTs for her head, were there more than one CT test for the head?
I don't remember. I'd have to look at my record.
Well, what are the normal, or what are the options for CT head scans?
It's usually just a CT head plane, but you could also do a CT angiogram, depending on your concern for injury.
And do you recall which one you ordered here?
For a trauma one, it would be a plain CT head.
And why do you order that particular test?
Well, we're trying to assess for skull fractures, intracranial bleeding, things like that.
And when you say a plain CT, what's the exact order that's put in for that type of a CT?
CT head.
Okay, and are there CT heads with contrast?
There are.
And are there CT head scans without contrast?
Yes.
And approach the witness.
Me.
I'm just going to show you some documents, if that's okay.
Sure.
I apologize, there's no series of paginations, so I'm just going to draw your attention to this page that's black. If you could just take a look at it.
Sure. Mm-hmm.
Okay, and I'm just going to flip to the next page as well. The next page is blank, but is this the extent of what you would have received as far as information regarding a head CT that was done without contrast?
Yes.
And I'm going to just draw your attention again to another flagged page here towards the end. It's actually 2 pages from the end of the document, if you could take a look at that.
Mm-hmm.
And does that reflect the report you would have received for the head CT ordered with contrast?
Yes.
And in addition to getting a report from imaging, you also receive some actual images, correct?
Yes.
And do you review those?
Yes.
In this particular circumstance, when it came to the patient of Lindsay Clancy, was there anything remarkable in either of those head CTs?
Not that I recall.
And in fact, the head CT with contrast indicated the impression was unremarkable. CTAF had no evidence intracranial aneurysm, arteriovenous malformation, or abrupt occlusion, correct?
Correct.
What does that mean?
It essentially means it's a normal study.
Now, as far as the other CT scans that were conducted, there were findings, remarkable findings on some of the others, correct?
Correct.
And what did they reflect in your experience as far as her injury goes?
From what I can recall, I know she had a thoracic spine injury.
And how about the CT that was done of the chest area?
I don't recall.
If I may approach.
Thank you.
Does that refresh your memory?
Yes.
And what was the extent of the results on the chest CT?
So it talks about her thoracic spine injuries.
Okay. Now, after reviewing all of the images, all of the CT scans that were done here, the cervical spine, the head CTs, the thoracic spine, what was the plan for this particular patient? Was she able to be treated further at Sejal Shah Hospital?
The decision was made by the team that her injuries were too severe to stay at Sejal Shah Hospital, and the decision was made to transfer her to a tertiary care center.
Were you able to stabilize her before transporting?
Yes.
Is that something that's important to make sure our patient is stable before sending him off in the ambulance or a helicopter?
Yes.
And so as far as this particular patient goes, are you aware of whether any surgical intervention had to be done before she was stabilized and transported?
I was not aware of any intervention being done.
And again, you had Dr. Carpio, who was also there to assess that.
Correct. We work as a team.
Kind of going back to those injuries on her neck and her wrist very briefly. Can you explain to us the difference between bleeding in maybe an artery or a vein and how that might present itself in an emergency situation?
Venous bleed would be a little bit slower, darker blood, and arterial bleed would be pulsatile and bright red.
And is it fair to say that when you strike either an artery or a vein that they're of different pressure systems, and so the manner in which the blood comes out is different?
Yes.
In either circumstance where an artery or a vein is struck or nicked or cut, would that be something that you'd have to stabilize for a patient in order to make sure that they don't bleed out?
Yes.
Was that done here?
It wasn't necessary.
Now, this particular patient at some point was noted to be, I think it was referred to as hypothermic. Mm-hmm. Do you recall that?
Yes.
Do you recall at what point in your treatment of her was that noted? Was it as she was coming into the emergency department, or did that develop while she was in the emergency department?
I don't recall.
What was the course of treatment for a low body temperature?
We placed something called a bear hugger on them, which is a warming blanket.
And can you explain to us what could cause a person's body temperature to drop to, I think it was 82.1?
There are many reasons, but it could be a metabolic disarray or exposure.
In this circumstance, did you know what the source of the drop in the body temperature was for Ms. Clancy?
No.
And do you recall how long she was in the emergency department before she was transported approximately to the Brigham?
I think it was about 4 hours.
At this time, Your Honor, I would move to enter into evidence a copy of the South Shore Hospital medical records for Lindsay Clancy from January 24th, 23 as the next exhibit.
Is that by agreement? All right. That may be admitted. Or they may be admitted.
And I would also move to enter as the next exhibit a certified copy of imaging records from the South Shore Hospital for Lindsay Clancy from January 24th, 2023.
All right. It may be admitted.
So finally, Dr. McDonough, did this defendant receive surgery at South Shore Hospital?
Not that I'm aware.
Okay. Did you observe any cuts, abrasions, or blood on the area of her head?
No.
And based on your review of those findings on the CT scans, was there any noted injury from the head CTs that you could tell?
No.
And were you able, after using that bear hugger device, able to get her her core body temperature back up to normal?
I don't recall.
Did you ever observe those wounds that you observed on her neck or her wrists ever start bleeding actively again?
No.
I have nothing further.
Mr. Reddington.
Morning.
Morning.
So, would you agree with me that when Lindsay was brought into the South Shore Hospital that she was unconscious?
I recall her eyes being open, but she was nonverbal. Okay.
So as an experienced emergency room doctor, can you tell me when someone's unconscious, what is that? What are the symptomology of it? What does that mean?
Usually means they're completely unresponsive with eyes closed.
Okay. Was she responsive?
Not verbally.
Was she responsive at all?
She was responsive to pain.
So that means that you would do something to cause pain, perhaps the bottom of the foot or whatever it is, to see if they have a reaction?
Correct.
And would you agree with me that when people even have very, very serious brain injuries, that they can respond to pain stimuli?
Sometimes.
Sometimes. So her eyes were open. Were her pupils equal and reactive to light?
I don't recall.
You don't recall. What does it mean with PERL, pupils equal reactive to light? What does that mean?
Exactly what you just said. It means her pupils are equal and reactive to light.
And as a doctor, what does that tell you?
It tells me that there's no significant neurologic injury.
And in this case, you don't recall if her pupils were equal or reactive to light?
I don't.
Okay. And that's when you take the little flashlight sometimes and you put it over the eye and see if there's constriction of the pupil.
Correct.
did you do additional evaluations of her to see what her neurological function was?
She was pretty quickly intubated from what I recall, so after that it would be difficult to assess her neurologically.
Sure. Was she on any pain medication, if you remember?
I don't remember.
You recall, did she have difficulty being intubated? I mean, would you agree with me that if you're not under some type of medication or sedation or unconscious, it hurts to be intubated, doesn't it?
We wouldn't intubate somebody without first giving them some induction medicines.
Okay. So what would the induction medicines be?
They're not universal.
Well, what
would depend on the
What are
case.
the induction medicines that you used on Lindsay Clancy?
I don't know. I'd have to refer to my record, and also I wasn't the one who did the intubation.
So she was intubated, had the tube coming out of her mouth, she's laying on the table, and you are continuing an assessment. You were the lead doctor in the emergency room for Lindsay Clancy, right?
I wouldn't say I was the lead. I think the trauma surgeon and I worked together.
Right. Her temperature, her core body temperature was 82 degrees. Is that right?
If that's what the record states, then yes.
I'm sorry?
If that's what her medical record states, then
Well,
yes.
as you sit here, you don't know what her core body temperature was?
I saw her 3 years ago. I see about 200 patients a
I'm
month.
sure you're very busy, but this is a murder trial, doctor. Did you review your records and your notes?
I'm happy to look at my record if you bring it
Did
here.
you review your records and notes before you came in here today to testify on this case?
Sir, I did, but I don't have a photographic memory.
Did she regain consciousness at all while she was in your emergency room?
No.
Can you tell me what CSF is?
Cerebrospinal fluid?
Yeah. Is that what that is? CSF?
But it could be. I'm not sure in what context you're referring to it.
Well, how about if there's a massive leakage of CSF from her nose? What does that tell you as a doctor?
It could mean that there's a skull fracture.
Did you notice any clear fluid coming from her nose?
I did not.
Is that something you would look for?
Yes.
How quickly do you get the results of the x-rays when you're in the emergency room?
Well, these were CT scans, but fairly quickly in a trauma.
I'm sorry, CT scans, x-rays. So you had CT scans that were able to show you the damage to her neck and upper chest. Is that right?
Yes.
And what did those CT scans show you?
Well, what I remember is a thoracic spine injury.
And when you say a thoracic spine injury, would you agree that top part of your neck, your throat area, would be cervical, right?
Correct.
And that's when the numbers go C1, 2, or whatever they are. That would be the actual vertebrae in the cervical area of the upper body, correct?
Yes, the cervical spine.
Okay. And then below the cervical spine would be the thoracic spine. Is that correct?
Correct.
And the thoracic spine would be, and sometimes they're delineated as T1, T2, meaning thoracic 1, thoracic 2, all the way down to what, 5 or 6?
12.
I'm sorry?
12.
12. So when you looked at, and the lower portion would be the lumbar. Is that right?
Correct.
Now, when you looked at the CAT scans, did you determine the extent of the injury to the spinal cord?
I could determine the extent of the injury to the bony thoracic spine.
Okay, what was that?
I don't recall exactly the level. I would have to look at the report.
What does that mean, the level of the T?
Correct.
Was her cervical spine injured?
I don't recall. I'd have to look at the report.
Were you aware that her thyroid was crushed?
I don't recall.
Do you know that her cervical spine vertebrae was fractured, destroyed?
I don't recall.
Doesn't that control a person's breathing? Does that have anything to do with breathing?
It can.
What do you remember about looking at the damage to the spinal cord depicted on the CAT scan?
What sticks out most in my mind is her thoracic injury.
Okay, and what was the thoracic injury?
I don't recall the exact level.
What does it mean by effect level?
The exact level.
I'm sorry. Were you aware that there was a complete transection of the spinal cord on T5 and T6?
I'm sure I was aware at the time, yes.
Okay. And just, can you tell me, what does it mean when it says a complete transection of the spinal cord at a particular, apparently that would be at thoracic 5 and thoracic 6, right?
Mm-hmm.
What does that mean with a complete transection?
It means the bones are no longer one on top of the other. They're moved apart.
Were you aware that there was a significant edema noted in her chest?
If that's what the report says.
Okay, and what is edema?
Swelling.
And does it also refer to fluid?
It can.
Did it refer to fluid in this case?
I'm not sure. I would have to read the report.
So in addition to the edema that was noted, was there edema noted around C7, T1, T2, T3 to T4?
Again, I would have to have the report in front of me.
When you noted her base temperature as being 82 degrees, what does that tell you as a doctor?
It means that her body temperature is lower than normal.
And what is normal?
98.6.
And if a person goes from 98.6 to 82 degrees before you place her in the bear hugger, what does that tell you? Does that affect the body at all?
Yes, the body works ideally at 98.6. So anything outside of that range, not ideal.
To what effect, as a doctor? What effect, if any, on the body if a person has an 82 degrees base temperature?
The list of things that could go awry is quite long.
Can you give me an idea, maybe the top 3?
She could have a metabolic derangement.
What's a metabolic derangement?
Meaning her body wouldn't be processing things the way that it was before. Her cells are not working the way that they should because it's too cold.
Would you agree with me that when you were looking at the injuries to the wrist and to the both wrists, actually, you noted lacerations in the volar aspect of the wrist?
Yes.
What is a volar? What does that mean?
It's the anterior aspect.
Interior? Okay, thank you. Would you agree that on both wrists there was deep laceration?
I wouldn't characterize them as deep.
You would not? And when you made reference to her being transferred to a tertiary care center, what does that mean?
It means that it's a hospital that has more services and specialized care than we do at our hospital.
Now, when she was at the South Shore Hospital, counsel asked you about whether or not you noted any injuries to her head. You did not notice any bleeding or scrapes or bruises of that nature, right?
Not that I recall.
Did you notice any injuries to her lower body, her legs, her feet, let's say her feet or her buttocks?
I don't recall.
At any time while she was at South Shore Hospital, did she have a cardiac arrest?
Not that I recall.
Do you know she had a cardiac arrest when brought to the Boston Hospital?
Did not know that.
How about blood? Was there any blood transfusion at South Shore Hospital Medical Center?
I don't recall.
Were you aware that she had a massive transfusion of blood once she hit Brigham and Women's?
No.
What does that tell you? Massive transfusion of blood. What does that mean?
I couldn't comment on why they gave it to her.
Were the police in the hospital when she was there with you?
I don't recall.
Was she chained to the bed by handcuffs?
I don't recall.
Go ahead.
You redirect?
Very briefly. Dr. McDonough, I'm just going to give you your notes, if that's okay.
Sure, thank you.
I'm going to just take a look at it and then take your time and just look up when you're done.
You need this
Do you
one?
want to just flip through the rest of them to see if that's the extent of the note that you had in the record?
Thank you.
Now, counsel asked you on cross-examination about pupils, right? Mm-hmm. Was there anything notable, according to your now review of the notes, about Lindsay Clancy's pupils?
No.
So what did that tell you about her a possible head injury?
It just indicates that there's no obvious head injury or brain herniation.
Now, you indicated that she was somewhat unresponsive, but her eyes were open. She was nonverbal, correct?
Correct.
Did you observe her to be moving her arms around at various points?
She did move her arms on exam in response to painful stimuli.
Okay. And as far as the intubation goes, you're aware that she was in fact sedated in order to maintain intubation?
Again, I'm not certain of that because I was not the one who performed the intubation.
Okay. And you were asked about CSF. Having now kind of looked through your notes with your interaction with this patient, was there any note of cerebral spinal fluid, in either your assessment of him or your review of any of the CT results?
I didn't see any mention of that in my physical exam.
Now, as an emergency department physician, you're not treating all of these spinal injuries, correct?
Correct.
Your focus is to assess, stabilize, and get them where they need to go, right?
Correct.
And so that's what you did with Ms. Clancy.
Correct.
When the injuries that were described as a volar aspect, counsel mentioned that terminology to you, right?
Yes.
You've now, in direct examination, identified those injuries as superficial. What characteristics make you say superficial?
Because I wasn't able to visualize any active bleeding or muscle tissue or injury to tendons.
And is it fair to say that oftentimes patients that come into the emergency department might be, if they have some sort of injury to their spine, you don't want them to move, right?
Correct.
So they might be at some point kind of either put in soft restraints or restricted on the bed.
Correct.
Thank you. Nothing further.
Is there anything further? All right. Thank you, Doctor.
Thank you.
The Commonwealth would call Rose Stoffers.
Good morning. Do you solemnly swear that the testimony you give and you the matter now pending between the Commonwealth and the Thank you.
Watch your step, please.
Hey, good morning.
Good morning.
Morning. All right, Attorney Buckingham, please.
Thank you. Good morning.
Good morning.
Could you please tell the jurors your first and last name?
Rose Stoffers.
Could you spell your last name for the record?
Stoffers.
And what do you do for work?
I'm a sergeant on the state police in the crime scene services section.
And how long have you worked for the state police?
Since January of 2019.
Can you tell us a little bit about what the crime scene services section is of the Massachusetts State Police?
Sure. So we get called to all different kinds of crime scenes. Our main job is to document the scenes with photos and videos. We can also process evidence on scene, or we collect evidence and bring it back to our lab and we process it there. We're processing for fingerprints, and then we do fingerprint analysis, try to identify any fingerprints we find on the evidence.
And fair to say the state police crime scene services have labs across the state, right?
Correct.
And what office do you work at?
Right now I work out of the Boston office.
Going back to 2023, were you working out of the Lakeville office?
Yes.
And so fair to say the troopers that are out of that Lakeville office do respond to a lot of scenes here in Plymouth County?
Correct.
I'm going to draw your attention to January 24th, 2023. Do you recall being called out to the South Shore Hospital in Weymouth on that night?
Yes.
And do you recall approximately what time you arrived there?
I arrived at about 8:35 p.m.
Were you by yourself or were you with anyone else from the unit?
I was by myself. I met then Trooper Lawler there. He's from the Plymouth Detective Unit, and I also met the forensic scientist there.
And can you explain to the jurors a little bit about that relationship that you as a trooper have with forensic scientists that work for the lab?
The forensic scientists are civilians who work for the lab, but they will come out to scenes as well. They do mostly testing of like biological evidence that we don't do. So we work closely with them both at scenes, and they share our office in Lakeville.
And fair to say that they're actually part of a different unit with the State Police Crime Lab called the Crime Scene Response Unit.
Correct.
But oftentimes is it the case that when you're responding to serious crime scenes like this one, that you're working in tandem with a forensic scientist from that unit?
Yes, that's correct.
Okay. And so in this circumstance, you indicated that Maureen Hartnett also was at the South Shore Hospital with you?
Yes.
When you got to the South Shore Hospital, what was the purpose for you being called out there? What were you asked to do?
So my instructions were to document the defendant, any injuries that she had. Forensic scientist Hartnett was going to be taking swabs, and anytime they take swabs, we have to document the areas in which they swab.
So when you got to the South Shore Hospital, do you remember where you went in the hospital?
Yeah, I went to one of the trauma rooms in the emergency department.
Okay. And so were you able to make observations of Lindsay Clancy?
Yes.
And do you see Lindsay Clancy in the courtroom?
Yes.
All right. Record may reflect the identification.
Thank you. What were your observations of her when you saw her?
She was covered in like blankets and like heating devices, and she had a neck collar on. So when I first walked in the room, I couldn't see anything on her body because she was under the blanket other than like the neck brace and her face.
May I approach?
You may.
Show you a photograph. Is that a fair and accurate representation of how you observed Lindsay Clancy?
Yes.
So we'll get this as the next exhibit, please.
Any objection?
I have no objection to any of the photographs.
All right. That may be admitted.
Exhibit 140. Sergeants, first I'm just showing you now what's been marked as Exhibit 140. Can you see that from where you're sitting?
Yes.
And so this blanket, that's how you observed her in the trauma room?
Yes.
Okay. At some point, did you and other medical staff remove the blanket to document injuries?
We didn't remove the blanket, but we did remove her arms out from underneath the blanket.
Okay. And so were you able to do that on your own, or did you need assistance?
I needed assistance.
And why did you need assistance?
When I first attempted to pull out her right arm, she was uncooperative and pulling it back and fighting against us a little.
So did you enlist the help of the nurses to help you to remove her arm from the blanket?
Yes.
Were you able to make any observations of kind of the temperature in the room at the time that you got in there?
Yes, it was very hot in the room.
Okay. And that blanket that you observed, were you aware that blanket was to kind of bring her body temperature up?
Yes.
When you were able to view her arms, when you first saw them, did they have anything on them?
There was a red-brown stain on her hands, and there was gauze on like her wrist area.
Did you enlist the help of the medical staff to remove the gauze?
Yes.
And why was that?
To document any injuries that might have been underneath.
And were you able to observe injuries?
Yes.
In addition to, strike that. The injuries that you observed or the areas of the body that you documented, what were they?
I documented, I took that first overall photo of her. I took a close-up of her face and the neck area that I could see. I documented both her hands, both sides of them, her wrist area underneath where the gauze was, and then the nurses assisted in opening up the neck brace, and I took photos of her neck as well.
And in addition to documenting the defendant herself, did you document any other items that were at the South Shore Hospital that evening?
Yes, I documented any personal belongings that were brought in with her.
And so you're aware that they removed clothing from her?
Yes.
And so you documented the clothing?
Correct.
And that she had 2 rings?
Yes.
And that you photographed those rings?
Yes.
And you're aware Trooper Lawler had retained those items?
I'm not sure who retained them from there.
Okay. But your role was just to document them?
Correct. I didn't take anything.
Okay. In regards to this particular case, well, go back for 1 second. In the crime lab, how does your unit, or how do you identify particular cases that you work on?
As in, like, being called out to something?
Well, is there a way that you, once you get called out to a case and do work on a case, is there a way to track what you did with each case by some sort of case number or lab number?
Yes, we have a case number associated with it.
And as far as lab numbers go, you're aware that the crime lab follows pieces of evidence using the same lab number?
Yes, that's correct.
And does that track items that go through your system?
Yes. So our lab number goes into a computer system and it tracks everything. It keeps every report written on that case. It tracks the custody logs. It tracks every piece of evidence that's been involved in the case.
If it helps you, there's no issue as to chain of custody or foundation or anything like that.
All right, thank you.
Thank you. Other than going out to the South Shore Hospital on January 24th, do you recall being called out to another location later in relation to the same lab number?
Yes.
And that would have been on January 6th, 2023?
February 6th.
Or, excuse me, February 6th, thank you. So where did you go?
I was called to the Plymouth Detective Unit's office in Brockton.
And did you meet or speak with one of the troopers from that office?
Yes, I did. Trooper Rabbit.
Trooper Rabbit. And what did he ask you to do on that day?
He asked me to photograph a bag of medication and some documents that were inside that bag that had been brought to their office.
Okay. And did you do anything else with the items that Trooper Rabbit had in his possession on February 6th?
No, I just photographed them and left them with them.
Okay. And again, is that something that your unit sometimes is called out to do?
Yes.
Okay. Nothing further.
Attorney Reddington?
So, is it trooper or are you a chemist? Or?
Sergeant.
Sergeant, sorry. Sergeant, you had a search warrant apparently when you went into the house, I guess, with Trooper Rabbit?
I didn't go into the house.
Oh, so he just gave you the bag. In other words, you didn't go in the house and take pictures of any of the rooms or anything like that?
No, the bag was at their office when I went to their office.
Oh, okay. All right, that's all I have. Thank you.
Anything further, Attorney Buckingham?
No, thank you.
All right, thank you, Sergeant.
Thank you.
Can we approach?
Yeah, please. At this point, so I'm going to ask you to go back. We'll get you back in here in a short while. Okay, thank you.
Court, all rise. Sure. Please go to the notebooks. Please among your chairs.
Session, please be seated.
All right, so we'll be in recess on this matter at this time. Thank you.
Court, all rise. back in session. You may be seated.
Your Honor, for the purpose of the record, we return back to the matter of Commonwealth versus Lindsay Clancy. All parties are present, including the defendant, excluding the jury.
All right. Counsel, we ready for the jury?
Yes, Your Honor.
All right.
Court, all rise. This court's now in session. You'll be seated, please.
Your Honor, for the purpose of the record, we return back to the trial of Commonwealth versus Lindsay Clancy. All parties are present, including the defendant and including the 18 jurors.
All right. Thank you. Commonwealth, call your next witness, please.
Your Honor, Commonwealth would call Rachelle Amede.
Watch your step, please.
Hey, good morning.
Good morning.
Inquire?
Yes, counsel, please.
Thank you. Good morning.
Morning.
Could you please tell the jurors your first and last name?
Rachelle Amede.
Do you mind spelling your first name for the record?
Rachelle. Last name is Amede.
Thank you. And how are you employed? What do you do for work?
I'm a nurse at Brigham and Women's Hospital, the trauma surgical ICU.
How long have you been a nurse?
Almost 27 years.
And can you tell us a little bit about your educational background?
I have a bachelor's in nursing from Salem State University.
And how long have you worked at Brigham and Women's?
20 years this week.
And which unit did you say you worked in?
The trauma surgical ICU.
How long have you worked in that unit at Brigham?
8 years.
Going back to January of 2023, were you working in that same unit?
Yes.
And what was the shift that you normally worked?
I work the night shift, which is 7 p.m. to 7 a.m.
And what was your schedule like for any given week? Did you work back-to-back shifts or?
I can sometimes work back-to-back shifts.
Okay. But you always worked the night shift?
The night shift.
Okay. I'm going to draw your attention to a particular patient that you had some interaction with in January of 2023, and that was Lindsay Clancy. Do you recall treating her?
Yes.
And was she in that trauma surgical intensive care unit?
Yes.
Do you remember the first time you interacted with her?
Yes, I got her.
And would that have been on the first night she was there on January 24th?
Yes.
How did she come to your unit at the Brigham?
She came from the emergency room, went to MRI, then came to the ICU to me.
And were you aware that she had been seen at a local hospital?
Yes.
In Weymouth, the South Shore Hospital?
South Shore.
While you were treating her on that first night, were you the main nurse assigned to her care?
Yes.
And what were your responsibilities as the nurse assigned to her care on that first night?
First night, she was intubated, came to me intubated. We had to maintain her blood pressure at a certain number, just care, regular nursing care.
Okay, and were you aware that she was on what's called a 1-to-1?
Yes.
What does that mean?
That means patient usually can't be left alone, and also depending, you always have to have somebody outside the room to monitor the patient.
And is that because that patient has been identified as a potential suicide risk?
Yes.
Okay. Now, on that, the 24th into the early morning hours of the 25th, was there a particular event that you were witness to for this particular patient?
She coded.
What does that mean?
Means her blood pressure dropped for her. It meant her blood pressure dropped and it wasn't sustainable with life.
So what did you do when her blood pressure fell and she coded?
We started CPR, we did compressions.
And this event occurred approximately at 3:30 in the morning, correct?
Yes.
Was she eventually stabilized after that code?
She was.
And did they do something as far as intervention to try to maintain her blood pressure?
We increased her pressors. We added 2 more pressors. She was already on 2. They placed chest tubes in, started what we call a massive blood transfusion protocol.
And did this all occur in the trauma surgical intensive care unit, or did she have to be taken to a different unit?
No, it all occurred in her room.
And other than medical staff that were treating her that particular night, did you observe anybody else present?
She had 2 police officers outside the room.
Okay, and so did they remain outside the room for the duration?
Always outside the room, yes.
As far as your interaction with the patient on that particular night shift, was she responsive at all during the time that you saw her?
No.
And with intubation, you mentioned she was intubated. Is a patient often sedated in order to maintain intubation?
Yes.
Why is that?
Helps them not fight the vent, breathe better, and make sure that they're comfortable.
And what does sedation do to an individual?
You're calmer, you're sleeping.
Makes them more relaxed?
Relaxed, yeah.
Other than that night, that first night, the 24th into the 25th, did you have the occasion to treat this patient at other points within that week?
Yes, I have.
And I'm going to draw your attention to January 26th of 2023. Do you recall interacting with her on that day?
Yes.
And is it fair to say that on the 26th she was still intubated?
She was.
And under sedation?
Yes.
Well, during this time period on the 26th, was she arousable, meaning could you initiate some communication with her?
Some, yes.
And were you able to kind of give her commands in order to care for her that she was able to follow?
Yes.
And when I say able to follow, obviously...
Simple, commands.
What kinds of
can you
commands?
squeeze my hand? Can you wiggle your toes? Just basic neuro check to just make sure she's alert and she's able to follow, understand what you're saying to her.
And for this particular patient, you're aware that she presented with a spinal injury, correct?
Correct.
And so movement of the lower extremities was not something that she did?
Correct.
But did you observe her to move her head around and move her arms around?
Yes.
Now, you also had the occasion to treat her in the overnight shift of January 28th of 2023, correct?
Yes.
And during that time, she was also still intubated?
I believe so. I'm not sure. I've had her both intubated and
okay.
extubated.
While she was still intubated, did you have a system that you could use to communicate with her?
Yes, board. We have a whiteboard or clearboard that sometimes patients can write on.
Did you observe her to utilize that whiteboard to write on it?
Yes.
And at this point, when she's writing on the board, her eyes are open and she's responsive.
Yes.
And she's able to tell you how she's feeling, correct?
Yes.
And fair to say she used that whiteboard to tell you she was confused and that she couldn't feel her lower extremities.
Yes.
And do you recall her complaining of having pain?
I don't recall.
During this time period on the 28th, do you recall whether the patient was placed into restraints?
Yes.
And why was that?
Well, we restrain all patients that are intubated for safety.
And why?
So they don't pull out the tube or pull out any lines that they have.
Okay, and so as they're not at that level of sedation anymore where they're just completely asleep, there is danger that they could move and cause damage to
medical equipment out of the way.
Okay. Yeah. And so in this case, as far as the restraints go, fair to say that they were soft restraints?
Soft, yeah.
And what does that look like for a patient?
Meaning?
Well, like what does a soft restraint look like?
A soft restraint, it's like maybe I would say a cushion restraint, and then it's tied to the sides of the bed. So it's all the way around your wrist.
Okay. At some point by the end of that shift, you recall that she was extubated.
Yes.
Can you tell us what extubation is?
That means you remove the tube. You usually stop all sedation.
Okay. And were you able to make observations of the patient once she was extubated?
Yes.
Did her presentation change at all from your previous interactions with her?
No.
Did you have the occasion to treat her again on January 30th?
Yes.
And again, at that point, she has already been extubated? And are you able to then make an assessment of her without the tube in about her orientation and her alertness?
Yes.
Is that something that you kind of do each and every shift?
Every shift, yeah.
Was she still on sedation medication at that time?
No.
And what was your observations of the patient's demeanor now that she is extubated?
She's flat, no emotion either way.
And is that fairly consistent with what your observations were of her during the course of your time treating her?
Yes.
How about being alert and oriented? Did you observe her to be alert and oriented?
She was.
And did you observe her to identify sleep as an ongoing issue?
Yes.
And so as part of the plan for treating her, did you address the sleep?
Yes.
And how did you guys address sleep?
The plan was to start the first sleeping medication for her. I don't remember exactly which one, and then wait a couple hours, see if it worked, and if not, try another medication.
Okay, and this actually occurred over the course of a few days,
few
correct?
Days, yeah.
During the time when you observed her to be flat, as far as her affect goes, did you also observe her to be cooperative?
Yes.
Meaning she followed your directions?
Yes.
Did you treat her, or were you the overnight nurse for her on February 2nd? You recall?
Yes.
On this particular night, February 2nd, do you remember her making a particular request of you or ask you for something specific?
I think that was the night she wanted to reach out to her lawyer.
And did you note that in your nursing notes?
Yes.
And why did you note that particular request?
Objection.
Can I see counsel? Yeah, counsel, go ahead.
Thank you. So on this particular night, the 2nd, she made a request of you for her lawyer, correct?
Yes.
Was that something she had asked you before?
No.
And so did you think it was something worth noting?
Yes.
Why would you note something like that?
Because that was the first time she referred to anything going on with the case. Or
okay, and so you had the occasion after she was extubated to have some casual conversation with her, correct?
Yes.
Okay. And this was not a conversation you'd had before?
No.
What did you do when she made that request? What was your response?
I sent what we call a consult to the social worker in order to coordinate reaching out to her lawyer.
In any of the shifts that you had been caring for this particular patient, did you see anyone besides medical staff and the law enforcement that were outside of the room come in and speak with her?
No.
Were you aware that she was not to have visitors?
Yes. I was told the first night.
And is that something that you've seen before in your work as a nurse when there are police on site?
Yes.
Were you present at one point when some troopers came in to take photographs of her?
Yes.
And were you in the room when they took the photographs?
Yes.
Do you recall assisting them in viewing the injuries to her wrists and her neck?
I don't know if I don't remember assisting.
Okay, but you were present.
I was present, like, in the room with her.
And fair to say, your contact ended with this patient on February 3rd when she was transferred off of the trauma surgical ICU unit.
Yes.
So, one moment.
Sure.
Now, you were not the only nurse to treat her on the night shift, correct?
Correct.
So on days that you didn't work, another nurse treated her?
Exactly.
And were you familiar with the nurse who was generally assigned to treat her during the day?
Yes.
And who was that?
Meghan Collins.
Meghan Collins. Mm-hmm. And is it fair to say that with the law enforcement presence and this patient's particular situation, the amount of medical staff that were treating her on a regular basis was fairly limited?
Correct.
Meaning it was the same
Yes.
people all the time?
Mm-hmm.
Okay. Thank you.
All right. Attorney Reddington.
Morning.
Morning.
First of all, you have the certified copies of the records from Brigham and Women's Hospital. I'd like copies.
All right. Commonwealth, any objection?
I actually have those on a disc. I was going to put the disc in instead of all the paper.
Why don't we put both in?
Sure.
We could do A and B.
Thank you. Now let's talk about a lawyer first, since that was the last that they asked you about. And correct me if I'm wrong on any of these dates or facts. She was admitted on the 24th of January. Is that correct?
Yes.
And do you have a memory as to approximately what time was it in the evening?
Well, she got to the ICU, it was around 3.
Okay. You're very soft-spoken.
Sorry.
You can just keep your voice up so all the jurors can hear you.
She got to the ICU around 3 a.m.
Thank you. And she came by med flight?
She came to me from MRI.
And MRI obviously would be when you're taking the pictures.
Picture,
yeah. And that would be on the 24th of January in the early morning hours, correct?
I think it went into the 25th.
Into the 25th?
I think so.
Counsel asked you about the whiteboard that she would write on. And I think it was, again, if I'm wrong, correct me, was it January 28th that she used for the first time the whiteboard to communicate?
Yes.
And the whiteboard basically is just a whiteboard, and,
Yeah.
and you write on it.
Erasable.
And she was not able to speak because she was intubated, right?
Yes.
And she was in the restraints that you've described as well, right?
Right.
Moving forward, January 28, 29, 30, into February 1st, February 2nd. It was on February 2nd that counsel asked you about her asking to reach out to her lawyer, correct?
Yes.
And do you know who her lawyer was at that time?
No.
Had you seen him before?
No.
Did you know, is his name Attorney Gelb?
No.
Make any reference to you?
No.
Do you know that whether or not she had conversation with Attorney Gelb regarding her status as being under arrest by the numerous police that were guarding the room?
I don't.
Do you know whether or not she was ever able to talk to Attorney Gelb, or did you refer her to the social worker people?
I put in a consult for the social worker.
Okay, thank you. When she was admitted on the 24th, would you agree that she was in the state of cardiac arrest shortly thereafter?
Shortly after arriving to me.
So I'm looking at the medical records that have been introduced for the jurors, and I'm referencing on page 18, if I may. Now, this is one page of 400 pages of medical records.
Can you see that?
But
All right, here we go.
looking at this, does it indicate it's an SICU course?
Surgical ICU.
I'm sorry?
Surgical ICU.
Okay. And that makes reference to the fact that shortly after arriving in the ICU, the patient had a cardiac arrest. Is that fair?
Yes,
Were you there then?
I was.
And when it says the etiology of the arrest, she got 2 rounds of CPR before obtaining ROSC. Can you tell me, please, what is CPR? 2 rounds, and what is ROSC?
Meaning we did chest compression. She was already intubated, so she was getting oxygen.
Okay. And then bilateral chest tubes were placed in her body?
Yes,
Does that mean from both sides?
both sides.
Okay. And that punctures through the chest into what, the lungs?
The lungs.
Okay, the lungs. And when they placed the chest tubes, at this point, shortly after admission, there was 100 to 300 cc's of blood from each chest tube? What does that mean?
That's the output they got once they put the chest
Sorry,
tube.
again, just can you keep your voice?
That's the output they got once they put the chest tube in?
Okay. So when they put the chest tube in, it drained 100 to 300 cc's of blood. Is that correct?
Correct.
And then after that, again, shortly after admission to the hospital, coming from South Shore Hospital, she then got a massive transfusion protocol, which you told us about, right?
Yes.
And what does that mean?
Means she gets, we have a protocol that with blood, depending, blood products,
Okay.
she gets infused rapidly.
And was there a notice shortly after arrival to the ICU, she was being turned and had 30 cc's of clear fluid that came out of her nose? Is that right?
Yes.
And what is that? Was there a suspicion that that was what's called CSF?
Yes.
And what is CSF?
It's spinal fluid.
Okay. Going to the next page, which would be 19, does it indicate, again, on there, if I can just bring this up a little bit better. So she now has noted acute blood loss, anemia, right? What does that mean?
She has a low blood count.
And do you know what happened to the blood, or any idea?
I do not.
So she had very low, lost a lot of blood, right?
Yes.
And she had anemia. That would be what, low blood or something?
Yes.
And she required multiple transfusions immediately following her arrest, right?
Yes.
And when it says arrest, does that mean arrest by the police, or does that mean the cardiac? I want to make sure that's clear. It's cardiac arrest, nothing to do with the police. Okay. And she had required multiple transfusions, and you were there for that, correct?
Yes.
Were you aware of the extent of after you had the after you had the MRIs and the CAT scans, were you aware as the lead nurse or treating nurse as to what the extent of her injuries were?
At that point, I don't believe so.
All right. At some point, did you become aware of that?
Yes.
Okay, so, and again, I've got the records, you don't, so let me do it this way, just to make it easy. Do you remember that she had a burst fracture of C1?
Yes.
What does that mean?
Means a cerebral fracture.
That'll be up here? So this is the cervical spine
Cervical.
up here?
Mm-hmm.
And then T5 and T6, there was a transection. What does that mean?
Thoracic.
Okay, so
On
that'd
the
be
spine.
about down here.
Yeah.
And when it says transection, what does that mean?
It's severed.
And then T1, 2, 3, 4 also were injured as well, right?
Mm-hmm.
What is neurogenic shock? What does that mean? If you know.
Neurogenic shock.
Sorry, yeah, neurogenic shock. It just makes reference on.
These are not my notes, so I can't really.
That's fine. I understand. And this would be on page 65. Do you recall reviewing the documentation as to what's captioned present illness in the records? Did you know that she was presenting as a transfer from South Shore Hospital?
Yes.
Did you know that that under present illness and the history would be that she's a 32-year-old female with history significant for postpartum depression? Did you know that?
Yes.
And did you know that after the fall with the C1 burst fracture and the complex transection of T5 and T6, she also had rib fracture, correct?
Yes.
On page 66, that would make reference to the time frame going into the 25th, on the 25th, that she was reacting to painful stimuli, right?
Yes.
And that basically means that she's not conscious, if you will, but she's able to react to...
If you cause pain.
Yeah. Okay. There's a notation of a contusion, laceration, and crushing of the thyroid with thyroidal edema. What does that mean?
She has swelling, I'm assuming, around her thyroid.
Okay, and that is...
Again, this is not my scope
of
practice. So.
Okay. On page 70, the same evening, making reference to the fact that in addition to the injuries to the spine, that she also had the rib fractures and was currently in shock. Do you remember that she was in shock? Yes, no?
Yes.
Okay. Would you agree, or do you recall that there's a notation that this patient is critically ill, and noting that she has postpartum psychosis on page 72?
Objection.
I see counsel.
When you're treating a patient, one of the things you try to do is to know what their total body and emotional condition is, what they've been dealing with, and what injuries they have, right?
We get a rundown or history of the patient.
Sure. And as it goes into the end of January, and she had been communicating on the whiteboard, you were aware at that point why she was in the hospital, right?
Yes.
You knew where she came from, South Shore Hospital, right?
Yes.
And you knew that there had been discussion about postpartum psychosis. Isn't that right?
Yes.
Okay. And do you recall that, and this would be on, may I approach you, Honor, the witness?
You may.
Thank you.
You can maybe, if you could show counsel. Wait.
I want the date and the time. Okay. And the lawyer, legal team. So I'm just showing you one page from the medical record. Can you tell me in terms of what date is this page from?
125.
January 25.
If I'd ask you if you keep your voice, at least speak in the
Oh, sorry. Yeah.
No, thank you.
January 25th,
Okay. Does it say what time?
9 a.m., 9:03 a.m.
All right. Can I see that for a second? Thank you. And looking at that, do you recall on that date you had been working with her the night before, correct?
Correct.
Where it indicates that the patient is under arrest, right?
Yes.
And there are police officers at her bedside. Right?
Outside the room.
Well, it says at her bedside on the record, doesn't it?
In the record, but I'm saying
and the night before,
they were outside her room.
outside the room. You were not there during the day, apparently, right?
Correct.
Okay. And there's a difference from you guys as far as your medical records. If the police officer is at the bedside as opposed to sitting in a chair in the hallway outside the room. Right?
Yes.
Okay. So indicating police officer at her bedside, we will involve the social work and legal teams, right?
Yes.
Okay. And again, on page 72, there's a reference to CSF leak, and that's significant. It says significant amount of fluid coming from her nose. Do you have any memory of observing that in your treatment?
I did.
Okay. And then, of course, there was the code event that you've already described for us. There's the 100 to 300 cc's of blood coming from the tubes, and then it makes reference to, on page 74, to massive transfusion protocol. Is that like a medical term, or is that somebody describing it? Or
it's a medical, it's a protocol that we have at the hospital.
Okay. And on page 75, did you make reference to, or did you observe the injuries, for example, to her wrist?
I observed.
Yes. And would you agree with me, page 75 of the medical record, indicating if it says RUE, what does RUE mean? Do you know?
Oh, right upper extremity.
Right upper extremity. 3.5 centimeter deep laceration. Volar aspect of wrist. Can you tell me what is the volar aspect of the wrist? I just don't know.
I'm not sure what that's referring to.
That's fine. Would you agree that there was noted a 3.5 centimeter deep laceration on her wrist?
I can't say because I didn't measure. This is somebody else's note, so.
Well, when you looked at her, did you observe with your own eyes and your own experience that she had a deep laceration on the...
She had a laceration, yes.
You can't say it's deep or not?
I can't say. I didn't.
You want to say it was superficial?
I can't say that either.
So when you looked at the laceration on her wrist, you
Yeah.
can't tell us if you would agree that it was a deep laceration.
I really didn't get to assess it at the time when she arrived. So.
LUE, underneath that, left upper extremity apparently, right?
Yes.
2 centimeter deep laceration, again, on the volar aspect of the wrist. You did see laceration on the left wrist?
Yeah, she had dressings.
Okay. And when she was admitted, she had the core temperature of 82 degrees. Is that correct?
If that's what's noted.
All right. Do you remember, did they use a bear claw or something like that? What is it they call it? They put
a bear hugger?
Bear hugger. They put a bear hugger blanket on them. And when I say them, I mean people that have a low
temperature to warm them up.
It hopefully raises the temp, right?
Yeah.
And then if it has warm intravenous IVF, that would be putting warm saline in the body?
Yes, through an IV.
All right, all with an effort to try to get the temperature up, right?
Yeah.
And her core temperature was 82 degrees even after she was at the South Shore Hospital and underneath the bear thing and all that, and still?
If that's what's noted.
Yeah.
Again, that's not my note.
That's pretty low, isn't it?
It is.
And you made reference to pressors. I'm sorry, can you tell me?
Pressors, blood pressure medication to bring up the blood pressure.
Okay. On January 26th, she was still intubated, is that right?
Yes.
And she was under sedation, right?
Yes.
And then you referenced January 28th overnight shift, she was still intubated, right?
Yes.
And January 28th is when she first started utilizing the whiteboard, is that correct?
Yes.
But she was intubated, yes?
Yes.
She was restrained to the bed,
yes?
And had the tube was still in her mouth, and she was writing on a whiteboard on the 28th of January, correct?
She was able to, yes.
January 30th, she was extubated, as the district attorney asked you, right?
Yes.
So at that point, was she able to talk, talk?
Talk.
Okay. And then on February 2nd is when she used she asked about wanting to reach out to her attorney. Is that correct?
Yes.
But you had no knowledge as to her mother and father getting an attorney for her while she was in custody with the police all around her?
No.
Okay. And you tried to help her out as best you could?
Yeah, to coordinate. It's harder at night
Sure.
So I wanted to pass it on.
And finally, she was not able to have visitors per order of the police. Is that correct?
Correct.
Thank you very much, ma'am.
Thank you.
Como, redirect.
Ms. Amede, the first time that Ms. Clancy, the defendant, the patient, used a whiteboard with you was on January 28th, correct?
Yes.
You're not aware of if she used that tool with other nurses on other shifts,
No.
were you?
No.
And the first time that she mentioned a lawyer on the February 2nd, that's the first time she mentioned a lawyer to you, correct?
Correct.
You were asked about the trauma in the chest tube and that she lost 100 to 300 cc's of blood.
Yes.
The transfusion came after that, correct?
Yes.
And fair to say the course of her treatment coming to Brigham was that she first came in through the emergency department, correct?
Yes.
Then she was sent for an MRI.
Yes.
And then she came to the trauma surgery, correct?
Yes.
And you're aware that she had other imaging like CT scans, correct?
Yes.
And that especially when it came to the head CTs, she didn't have any intracranial injuries or anything that required that you be focused on her head injury, correct?
Correct.
So it was more a cardiac issue and keeping her stable and internal bleeding in the chest area.
Yes.
As far as what you're aware of from other treating physicians. You're aware Dr. Anderson was one of the trauma surgeons that was treating the patient?
Yes.
And he was making assessments and giving orders to you and other nurses, fair to
Yes.
say? And are you aware that he identified in the history that this patient actually had a history of postpartum mood symptoms, not psychosis?
I would have to look at the note. I don't remember.
Those aren't notes that you would have written?
No.
And you weren't taking a full history of the patient?
Not at the time, no.
Were you aware that she then subsequently was fully evaluated by the psychiatric team?
I knew she saw psych, yes.
And were you aware that they ultimately identified that there's an inherent uncertainty in her diagnosis?
I do not remember.
Okay. As far as the lacerations went, in your treatment of her, again, you treated her overnight shifts for various days, correct?
Yes.
Did you ever have a situation where you had to change her bandages because they were seeping?
No.
And are you aware that
except for the first night, but we didn't get to that because she coded.
Because she coded.
Yeah.
And then you're aware that the next day after, another individual, a physician's assistant, actually came in and treated those lacerations.
Sutured, yeah.
And as far as Dr. Anderson goes, were you aware that on January 25th, he noted that the lacerations to her neck and wrists were very superficial and didn't require treatment at that time?
I was not aware. Don't remember that note.
Would you, if I showed you the record that's in his note, would you agree that that's an assessment that he made?
Yes.
Okay. And he didn't instruct you to do anything further with those injuries?
Yes, right.
Thank you.
Very briefly. Sure. District Attorney asked you about the evaluation by the, as she put it, psychiatric teams with a determination that there was inherent uncertainty according to the psychiatric teams. Do you know when the psychiatric teams were evaluating her?
I don't know. It was during the day. I don't know what day, but.
But in any event, I did show you on the thing over there where the reference was made to postpartum depression, postpartum psychosis, correct?
Yes.
And that's all I have. Thank you, ma'am.
Anything further?
No.
All right, thank you, ma'am. Let me sit down. Thank you. All right, Como.
The Commonwealth would call Meghan Collins.
Please.
Hi, good afternoon.
Hi.
Ask you to speak into that microphone, keep your voice up.
Okay.
All right. Attorney Buckingham, please.
Thank you. Good afternoon.
Hi.
Can you please tell the jury your first and last name?
Meghan Collins.
Would you mind spelling your first name for the record?
Meghan.
And-
Collins. Collins.
Thank you. And what do you do for work?
I'm an ICU nurse.
And how long have you been a nurse?
11 years.
And did you go to school for that?
Yes.
Where'd you go?
Sacred Heart.
What hospital do you currently work at?
Brigham and Women's.
And how long have you worked there?
8 years.
In January of 2023, what unit were you working on at the Brigham?
The trauma surgical ICU.
Did you work a particular shift?
I did.
And what shift was that?
7A to 7P.
So 7 a.m. to 7 p.m.? And you just have to answer out loud, sorry.
Okay, yes.
I'm going to draw your attention to a particular patient that was treated there beginning on January 24th, Lindsay Clancy. Are you familiar with that patient?
Yes.
Were you a nurse that was treating her during the day shift while she was in the ICU?
I was.
Are you aware that she arrived at that Brigham Hospital on January 24th of 2023?
When she was admitted to our ICU, it was overnight.
So as far as the hospital, do you know when she arrived at the hospital?
I believe the evening prior.
And you, a patient who comes to your hospital doesn't automatically come to the ICU, correct?
That's correct.
Where do they go first, usually?
The emergency room.
And you're aware this particular patient actually went through a local hospital before being transferred to the emergency department at Brigham and then to the ICU, correct?
Correct.
And so when you interacted with her, she had already been at the ICU unit for that night shift. Is that fair to say?
Correct. Interacted. She was intubated when she arrived.
And were you with her the entire day of the 25th from that 7 a.m. to 7 p.m. shift?
Yes.
And was she on what's called the one-to-one during that day?
Yes.
And what does that mean for you as the nurse if she's on the one-to-one?
She was one-to-one nursing per our ratios because of how critically ill she was.
And so you were there pretty much the entire time?
Correct.
Were there any other people there other than the medical staff and yourself treating her? Were there any other people there?
There were officers, police officers.
And they were outside the room?
Correct.
Had you taken over care of this patient from another nurse on the night shift?
Yes.
And who was that?
Rachelle.
And you are familiar with Rachelle? You've worked with her before?
Yes, I have.
And were you advised that over the course of the night shift that this patient had coded?
I was.
And when you came on shift in the morning, because of what had happened overnight, were you aware that she was sent for additional CT scans?
We went for CT imaging in the morning when I got there because she was not stable overnight.
Okay. And you said she was intubated, correct?
Correct.
How about, was she responsive during that first day that you encountered her?
The first shift that I had her, we were focused on her injuries and keeping her sedated. So the interactions, responses were minimal, but that was intentional as she was, again, like I said, so critically ill.
And so you also said that she was sedated for the majority of that day, correct?
Yes.
And is that something that often happens when a person is intubated, that they're sedated?
It is.
What happens if an individual isn't under sedation and they're intubated?
It is patient dependent, but majority of patients are not able to tolerate the breathing tube and it's uncomfortable. So we give them medications to keep them as comfortable in tolerating the breathing tube as possible.
Now you mentioned treating injuries and keeping the patient stable as your primary goal, correct? Were you able to make note of some physical injuries that the patient had?
Yes.
And were there some obvious injuries that you could observe?
Yes.
To her neck and wrist area?
Correct.
May I approach the witness? Just going to show you two photographs, okay? Does that look familiar to you?
Mm-hmm.
Do you know
Yes.
that to be the patient, Lindsay Clancy?
I do.
And fair to say she has a breathing tube?
She does.
And then the second one, again, just the other side of her neck. Is that familiar to you?
Yes.
Are these very inaccurate representations of the neck injury that you observed for this particular patient?
To the best of my memory, yes.
All right, they may be admitted.
142 and 143.
I'm going to show you on the screen what's been marked as Exhibit 142 and 143. And you said that's, to the best of your memory, what the injuries on her neck look like, correct?
That's correct.
And during your treatment of her, did those injuries require constant attention?
They required dressing changes. It did not require constant attention. She had multiple injuries.
So fair to say she had more significant spinal injuries and other issues that you were working to stabilize her on, correct?
Correct.
Now, you treated her on the 25th, right? And did you treat her on the 26th? To your best of your memory?
I would have to go back and look.
I don't have a problem if she leads her with records if she does.
As far as January 26th on that 7 a.m. to 7 p.m. shift, do you recall making notes that the patient required additional sedation due to the tube intolerance?
Yes.
Okay. And that she was started on low dose of propofol?
That is correct.
And that in the afternoon that she had chest tubes and you kind of checked those chest tubes to, it says, interval CXR looked okay with chest tubes to water seal.
Yes, that's correct.
And so she had previously been given chest tubes and your role was just to kind of make sure that everything was fine.
They placed bilateral chest tubes, and monitoring those is a part of my responsibilities in the ICU, and we were concerned for her respiratory status, so that is why I made a note of it.
Okay. And as far as the injuries that were a part of your assessment of her, fair to say on January 29th, you also were treating her that day from 7 a.m. to 7 p.m., and you made a note where you identified injuries, right?
Correct.
And those injuries would have been things that were reported to you based on a doctor's review of labs and images and that kind of thing, correct?
Yes.
You don't make your own assessment about thoracic injuries or cervical injuries?
I do not diagnose.
Also on the 29th, or the 28th into the 29th, that is at that point when the patient was extubated, correct?
Correct.
Do you recall making observations of the patient when after she was extubated?
She was not extubated on my shift. I was there the following day.
Okay. Did you note how her demeanor, her presentation the next day?
I did.
And fair to say you noted increased confusion, agitation, and picking at lines and drains, correct?
That's correct.
And fair to say the patient had to be restrained because of the activity?
That is correct.
Is that something that you often see when patients come out of intubation, that when they're extubated that they exhibit signs of confusion or delirium?
Yes, it's called ICU delirium.
And over the course of the next few days in your interactions with her, did you see that delirium decline or decrease?
Yes, it was a multimodal approach to manage the delirium, agitation, and it did get better and it did improve.
And fair to say during the time that you were treating this particular patient, there was also sleep issues that were part of the treatment plan?
That is correct.
And on January 29th and January 30th of 2023, were you present when the psych consult team came in to speak with the defendant?
Yes, I was.
Okay. What was the purpose of you being present?
The purpose is we had consulted the psychiatry team to evaluate and determine capacity, and my role is the as the ICU nurse is advocacy on behalf of the patient and to alert the providers if there's any changes in the mental status.
Now, when they came in and you said advocate for their position, you're aware that the patient was looking to change her healthcare proxy, correct?
The patient was changing her healthcare proxy. That is correct.
And that there has to be an evaluation to determine whether she's of a particular mental status and medically able to make that decision on her own. Is that fair to say?
Yes.
Okay. And do you recall who was present other than yourself and the psych doctors, the doctors from the psychiatric unit?
There was the social worker, myself, and her lawyer was present.
Had you been present when a lawyer or somebody else was with her prior to this consult?
No.
And fair to say, you were made aware very early on that there was a particular group of people that would be having access to this individual, correct?
Can you clarify?
Well, is it fair to say that the treatment team was kept small on purpose? And the same people were coming in and being the nurse, day and night staff. There was limited access. Is that fair to say?
It was kept to a smaller team, but that was also protection of privacy for the patient.
And during the course of time when she's on the ICU, which is between the 24th to February 3rd, there's always law enforcement posted outside the room, correct?
Yes, and it was because she was...
Well, I'm just asking you if there were law enforcement.
There was.
Okay. Do you recall having to check with the nursing director and the legal team at the hospital to make sure that it was permissible to allow anyone in besides medical staff?
Yes, that's standard protocol.
And when she was transferred off of the your unit on February 3rd, did you have any further contact with her?
I did not.
Nothing further, thank you.
All right. Attorney Reddington.
Afternoon, I think. Yeah. How many years you been a nurse?
11.
And you obviously take that position as very serious, and your concern is to protect your patient. Is that right?
That is.
You made reference to the fact that she was changing her documents as far as healthcare proxy.
Yes.
Did you know anything? Did you know who she was changing it from, her husband to her mother and father, or did you know anything about the specifics?
She was changing it from Patrick to her parents.
Thank you. And finally, what is a DNR?
DNR means do not resuscitate.
Do you know what her DNR was?
Her code status was full at the time that I took care of her.
Do you recall that she had indicated repeatedly that she wanted a DNR, that she did not want to be resuscitated if emergency arose?
I was not privy to that knowledge.
Okay, but that's noted in the medical record. It would be noted in the records, right?
It would be, yes.
Thank you very much.
Thank you.
Attorney Buckingham.
No, nothing further, thank
All right.
you.
Thank you. Please sit down. Thank you.
Commonwealth calls Dr. Shah.
Afternoon. You solemnly swear that the testimony and the evidence you shall give to the court and the jury in the matter now in the Commonwealth of
All right, good afternoon, doctor.
Hi.
I'm going to ask you to keep your voice up and speak into that microphone, all right?
Thanks, Your Honor.
Thank you.
Thank you, Your Honor. Good afternoon. Can you please state and spell your name for the record?
Sure. My first name is Sejal, S-E-J-A-L. Last name is Shah, S-H-A-H.
What's your date of birth?
5/8/81.
What do you do for a living?
I'm a psychiatrist.
And can you briefly describe your education and training background that qualifies you to be a psychiatrist?
Yeah, absolutely. So I did my undergraduate in Philadelphia at the University of Pennsylvania, followed by medical school at Jefferson Medical College, also in Philadelphia. I moved up to Boston to do my residency in psychiatry at Brigham and Women's Hospital and Beth Israel Deaconess, followed by a fellowship in consultation liaison psychiatry at Brigham and Women's Hospital, and then stayed on as a faculty member.
And where do you work currently?
I work at Brigham and Women's Hospital.
And what is your role there?
I'm Associate Chief of the Division of Psychiatry and Medicine, leading the consultation liaison psychiatry service at Brigham.
And what is the consultation and liaison service?
Yeah, so consultation liaison psychiatry is a subspecialty of psychiatry that works at the interface of psychiatry and medicine. So we work both in the inpatient and outpatient settings. In this particular instance, we get called by other healthcare providers that may need help with their patients or have a question related in the psychiatric realm. And so I would see a patient that's admitted to the hospital and help provide recommendations to the physicians and the rest of the care team that's caring for that patient.
So basically, say at the Brigham, if a patient's being treated there and a medical doctor is treating them and thinks that they need a consultation with a psychiatrist, your department would be called.
That's correct.
Okay. And how long have you been with the Brigham?
19 years.
Now, I want to direct your attention to January of 2023. Did you interact with a patient named Lindsay Clancy?
I did.
And was that on January 29th, 2023?
Yes, that was the first of a handful of times that I saw her.
And why did you meet with Lindsay Clancy on January 29th, 2023?
So my team was seeing Ms. Clancy for a number of reasons, including for psychiatric safety risk assessment. She had come in reporting a suicide attempt, which is a common reason why my team would be called, is to continue to ensure that patients are safe when they're in the hospital. So we make recommendations about kind of safety status, what can we do to help keep a patient safe, but then we also make recommendations related to medications. So that's why my team was following her. So that was one of the reasons why I saw her on the 29th, is to continue that assessment. I was also called to ask I was asked a new question that day, a consult question on whether she was able to make the decision to change her healthcare proxy from her, at the time, husband to her parents.
And when you consult to help determine whether someone's capable of making a decision like that, changing their healthcare proxy, are you evaluating their medical decision-making capacity?
That's correct.
Okay. How do you go about doing that?
So there's generally 4 parts to medical decision-making capacity. The first is whether somebody's able to voice a choice and whether that choice is consistent over time. The second is whether they understand the situation under which they're making that choice. The third part is appreciation of the risks and benefits. And the fourth part is kind of being able to reason or rationalize that information to be able to come to a choice and how they came to that choice.
Now, if you're doing this evaluation to determine someone's capacity to make decisions, would a traumatic brain injury factor into that evaluation?
It could.
When you evaluated Lindsay Clancy, was she able to voice a choice to you about who she wanted to be her healthcare proxy?
Yes.
And is she speaking to you or writing this down?
She's speaking.
So she's already been extubated at that point?
That's correct.
And she's speaking to you, and were you aware that Patrick Clancy was her healthcare proxy?
I was told that by her primary medical team.
Okay. And when you talked to Ms. Clancy, did she tell you who she wanted to take over that role?
She did.
And who was that?
Both her parents.
And you talked about that needing to be a consistent choice. How did you ensure that was a consistent choice with her?
Yeah, so we waited to make the change from Patrick Clancy to her parents until the next day for a variety of reasons. We wanted to ensure that that choice was consistent over time, and especially because the day that I saw her, she had just gone through some pretty major medical events, including she had a major spine surgery, a decompression and a fusion. She had gone through some oxygen desaturation overnight, so was not breathing as well. Her heart rate was up, all of which then led to her being what we call delirious. She was confused overnight to the point where she asked her nurse, "Am I delirious?" And she was also experiencing some visual hallucinations. So that was one of the reasons why I was called in, to make sure that she was able to make that decision to change her healthcare proxy. And then in addition, the team had also voiced, concerns that she had come in after a reported suicide attempt. And so making sure that she was able to make that decision of sound mind. And so we actually waited until the next day when she could be reassessed. At that point, her delirium had cleared, and she was continuing to make that consistent choice to change her healthcare proxy to her parents.
And in fact, you noted in the medical records that the hallucinations were part of an issue with oxygen.
It could be. That could be one of the reasons. Delirium is usually due to a variety of different medical reasons, and oxygen desaturation could be one of them. She had also just recently had anesthesia related to a surgery that she had on her spine, so that could be another reason. And then her heart rate was also actually quite elevated, so that could be another reason.
Is it common for patients who are just coming off of anesthesia from surgery, who have an issue with oxygen and other medical issues that you described, to have visual hallucinations?
They can. It's not that everybody does, but they can. And delirium can be quite common after surgery, and particularly anesthesia.
And those hallucinations that she was having, those were resolved by the next day. They were over by the next day, correct?
That's correct.
And her choice to change her healthcare proxy to her parents was consistent the following day, correct?
That's right.
You also talked about the patient has to understand the risks and benefits of the decision, correct?
That's correct.
How do you make sure the patient understands that?
Yeah, so one of the things we do is really ask patients to take us through their thought process of why they're making that decision and what led to them making that decision at that moment in time. So we're able to kind of see their thought process and ensure that they're understanding, what it means to remove one person and add another.
And what was Ms. Clancy's thought process in explaining that to you?
Yeah, she was saying that her parents are quite supportive to her, and that she was thinking that she would have to change her healthcare proxy from her husband to somebody else. And we didn't necessarily go into the reasons as to, why she would have to change it, but she explained that she was very close with her parents. They would see each other frequently, given that they lived in close geographic proximity, and that she felt that they were very supportive to her and would have her best interests in mind should we need to invoke the healthcare proxy, or that if she couldn't make her own medical decisions.
So was there a concern on her part that her husband wouldn't have her best interests in mind at that point in time?
Sustained.
You also talked about the patient. You have to make sure the patient's thinking about the information rationally. How do you go about doing that?
Yeah, so one of the things we do is really ensure that the patient understands the situation and, all of the kind of parts around it. So this comes into play much more when it's about a specific medical intervention, like an invasive medical procedure, or something like an amputation or a surgery. With a healthcare proxy, one of the things you want to make sure is that the person that they want to change their healthcare proxy to or appoint as their healthcare proxy makes sense in the context of their life. Ms. Clancy was able to talk about how her parents were quite involved in her life. And so that's one of the things that we would assess.
Okay. And then the last thing was making sure the patient understands the risk if the change doesn't happen. Mm-hmm. Did you go over that with Ms. Clancy, and how did you do that?
Yeah, I did go over that with her. We talked a little bit about how it could mean that she would not have a healthcare proxy were she not to appoint her parents. And so we went through that, it's always in healthcare, we always talk about how it's great to have a healthcare proxy just in case you become unable to make medical decisions, and who would you want that to be?
And during this conversation with the defendant going over all these points, did you ever have difficulty understanding her?
I did not.
Did she ever appear to have difficulty understanding you?
So the first day when I saw her on January 29th, she described herself as feeling confused, and I definitely witnessed that as well. We went through a bedside cognitive evaluation, and she definitely made some mistakes on some of the cognitive evaluation. Therefore, I did diagnose her at that time with delirium.
And then she was re-evaluated the following day, and there were no issues with her understanding, and the delirium was gone, correct?
That's correct.
And were you aware during this evaluation that Ms. Clancy did not have a brain injury?
I'm sorry, can you repeat the question?
Were you aware that Ms. Clancy did not have a brain injury at that time?
One of the things that we look at is any kind of relevant medical information that might be available to us. And I noticed that her Glasgow Coma Scale, when she was transferred to Brigham and Women's Hospital, was a 10, which would indicate that she could potentially have had a moderate brain injury. But I don't recall thinking about whether, specifically whether she had a brain injury.
Were you aware that a CAT scan was done, page 110 of the records, and on the CAT scan, the impression was no acute intracranial findings, so no brain injury.
So you can.
CAT scan,
I did review the head imaging that was available at the time. You can have a normal CAT scan and still have a brain injury.
Were you aware that she had multiple CAT scans that showed no bleeding in the brain, no skull fractures, no injuries, just visible injuries whatsoever?
I'm sorry, but can you repeat the question?
Were you aware that she had multiple CAT scans at South Shore Hospital and at Brigham and Women's that showed no skull fractures, no intracranial bleeding, no hemorrhaging, no visible damage whatsoever?
Yes.
Okay. And were you aware that she was evaluated at South Shore Hospital and at the Brigham, and she had no external injuries on her head either?
Yes.
Now, she was allowed to change her healthcare proxy to her parents, correct?
That's correct.
So if someone was had an injury, a brain injury, to the point where they didn't know what was going on, or they were having trouble processing or thinking, they wouldn't be allowed to change their healthcare proxy, correct?
It depends to what extent. Most patients that have either a head injury or severe mental illness, let's say, just anything going on with the brain, retain the ability to make most medical decisions. And we think about changing healthcare proxies as a pretty low risk decision. As I mentioned before, something like an amputation or a major surgery, invasive procedure is something that we would hold somebody to a higher bar. But a healthcare proxy is a pretty low risk, especially if it makes sense in terms of who they want to change it to.
And when was her Glasgow score 10?
I believe it was as she was being transferred from the outside hospital to Brigham and Women's.
And you're seeing her several days later, correct?
Correct.
And so when she was transferred from the outside hospital to Brigham, she was unconscious, correct?
I believe so.
Okay. So now she's conscious, correct?
That's correct.
And when she was transferred from the outside hospital to Brigham, she wasn't communicating or speaking or opening her eyes on her own, correct?
That's what the report said. I was not there at that time, but the notes that I read, that's correct.
So when you're speaking to her a couple days later, she's opening her eyes, she's communicating, she's responsive, she's interacting, correct?
Yes.
So it's fair to say that her Glasgow score would be higher than the 10 when you were speaking to her, correct?
Yes.
Now, you did a mental status examination of her while you were doing this evaluation about her decision-making capacity, correct?
Yes.
And it's fair to say under mood you listed okay?
Yes.
That you listed her thought process as organized, goal-directed. Is that correct?
Yes.
You asked her if she was having hallucinations or delusions, and she, other than those initial ones the first day, she denied those?
During my evaluation, yes.
And she also denied suicidal intent and homicidal intent, correct?
Yes.
And you listed her insight and judgment as fair, correct?
Yes.
Her behavior was calm and cooperative?
Yes.
And you didn't see anything about her behavior that would indicate to you that she was responding to some type of voices or hallucination that you couldn't see?
At that moment, no. But as I mentioned, I did speak with the nurse beforehand, and Ms. Clancy was able to report to me that she reported visual hallucinations overnight.
Overnight after surgery?
That's right.
Okay. And then never again?
Not during my evaluation.
Okay. And did you speak to Ms. Clancy again on February 19th, 2023?
Yes.
And was the purpose for that to prepare her for a transition from Brigham and Women's to Spalding Rehabilitation?
That was one of the reasons.
Okay. And what were the other reasons?
So it was an ongoing safety evaluation, ongoing evaluation of psychiatric safety risk, as well as medication evaluation to determine if her medications were at the right level, the right dosage, and that she was on the right medications, and then just ongoing evaluation in terms of kind of her mental status.
And during that meeting, she denied suicidal intent, correct?
That's correct.
She denied homicidal intent, correct? She denied having auditory or visual hallucinations, correct?
Yes.
She reported her mood as okay, is that correct?
Yes.
And she told you she was looking forward to moving to Spalding, correct?
Yes.
She also denied any confusion or disorientation, is that correct?
Yes.
And again, you described her mood as okay on that day?
Yes.
And you described her as future-oriented on that day?
Yes.
And then you spoke to her again on February 21st, 2023, is that correct?
Yes.
And on that day, is this the same purpose that you just described, getting her ready, assessing her mental status and getting her ready to transfer to Spalding?
Yes.
Okay. And during that time, you wrote that the patient reported feeling down about her current situation, her paralysis, and the events leading up to her hospitalization. Is that correct?
Yes.
And you also noted that she said her thoughts about what she had done were not constant throughout the day, correct?
Correct.
So she wasn't thinking about killing her children throughout the day, every day, correct?
Correct.
And she said she had no suicidal intent, no homicidal intent, correct?
Correct.
No auditory or visual hallucinations, correct?
Correct.
You also write no PI. What does PI stand for?
Paranoid ideation.
And there was none of that either?
Correct.
You also made a note, notes low mood today in the context of her physical and legal situation, but does not currently meet criteria for major depressive episode. Is that correct?
Yes.
So her focus seemed to be on her physical and legal situation, but being hopeful about moving on to Spalding.
Okay. Could I see counsel?
And so her focus at that time appeared to be her physical situation, her legal situation, and looking forward to going to Spalding rehab.
Yes.
And then your last visit with her was February 22nd, 2023, correct?
Yes.
And again, she indicated she was hopeful about treatment at Spalding.
Yes.
She was future-oriented.
Yes.
And she denied suicidal ideation, homicidal ideation.
Yes.
She denied audio hallucination, visual hallucination, and anything else of that nature.
Yes.
Thank you.
Attorney Reddington.
Afternoon. So, doctor, from your testimony, and correct me if I'm wrong, was she, to your opinion and your experience, an honest patient telling you what her symptoms were, if any?
Objection.
That's an evaluation in the psychiatric.
I'll allow that question.
Yes.
In other words, she didn't go off and try to exaggerate to you and say, I'm seeing visions and I'm hearing voices and I'm suicidally ideated and I'm homicidally ideated. She didn't say any of those things to you, did she?
No.
She actually denied them, right?
Correct.
So this is not, in your opinion, someone who was trying to exaggerate her conditions for some legal reason, correct?
No.
And you obviously were in close contact with her for about a month, right?
That's right.
Just a couple of questions. Counsel asked you whether or not, and I think it may have been in the beginning in January, that you had difficulty understanding her. Obviously, after removing the tubes and everything else, you're able to talk with her, correct?
Correct.
And you knew that one of the concerns, if you will, was postpartum issues. You knew that, right?
Yes.
And in your experience as a psychiatrist, you're familiar with the concept of postpartum psychosis, correct?
Yes.
And you know that people can communicate and plan and act on plans even if they're in the middle of a psychosis, right?
Yes.
You don't have to be drooling and stumbling and unable to walk and talk to be in a psychosis, do you?
No.
So in other words, a person can be in a psychosis and can communicate to friends, family, people, talk, correct?
Yes.
So you didn't, as counsel asked, you didn't have any difficulty understanding her. She wasn't slurring her words or anything like that when she was able to talk.
Right.
Okay. One of the things that when she was admitted, and then without going through, I'm not going to go through all the stuff we've already talked about with the medical condition and everything else, you indicated that she was very, very ill, correct?
Correct.
Did she appear to be cooperative to you when you would interact with her?
Yes.
As a doctor, as a psychiatrist, you're familiar with bipolar, the concept of a bipolar diagnosis, correct?
Correct.
Can you tell me what bipolar means?
Yeah, so bipolar disorder is a mood disorder, categorized as a mood disorder, where patients have distinct depressive episodes, as well as, depending on the type of bipolar disorder, either hypomanic episodes or manic episodes, to the point where they don't sleep for days, they still have lots of energy, there's this decreased need for sleep, there could be irritability, there can be impulsiveness, racing thoughts. A lot of patients describe that they're out of control of their behavior, and then severe episodes can also include psychosis.
And in reference to bipolar, as you were referring to, when somebody is hypomanic, what does hypomanic mean?
Yeah, it's a lesser degree of mania. So when patients are hypomanic, they don't always experience things like psychosis, but they might experience some of the other symptoms that I described, including racing thoughts, kind of moving too quickly, talking too quickly, being irritable.
And as it relates to the hypomania, would that include things such as somebody who is getting up early in the morning and exercising, or cleaning out their house, or selling their property out of a garage and having difficulty sleeping, and they're awake all night?
Yes.
As a psychiatrist, one of the things you were concerned about when you were first started to deal with her, as well as when you were releasing her, if you will, is the medication that she had on board, so to speak, when she came into the hospital, right?
Yes.
Do you remember, and I know it's difficult to recall offhand, but do you recall the medications that she was actually under from purposes of taking her blood when it was tested?
When she first came to the hospital?
Yeah, if you know.
I believe her medication list for, previous to the incident, she was on amitriptyline, diazepam. I believe she was also on prescribed lorazepam, and there may have been one other.
Okay. So looking at that, if I tell you that there was a toxicology report done on her as of January 24th by way of taking her blood, you're familiar with that, right, when they analyze for toxicology? And toxicology obviously would tell us what the medications, if any, what type of drugs she had on board, booze, cocaine, anything, right?
Yes.
And you're aware that the toxicology report, as well as the report from the Department of State Police, as well as the NMS laboratory, which would be in Pennsylvania. So that's an international or a national respected laboratory, isn't it? The NMS lab, if you know?
I don't know.
Okay. But you know that they did take her blood, they did test her blood, and it was at the State Police laboratory as well as any other labs that tested it, right?
Yes, I believe I found that out later. I did not know that the first time I saw her because those labs take a little bit of time to come back.
And you treated her for about a month, so you were pretty close to her and got to know her quite well?
Yes.
Would you agree with me that one of the things that her blood reflected or that she was on was trazodone?
Yes.
And can you tell me what trazodone is?
Yeah, trazodone is an antidepressant medication. It's more often utilized as a sleep aid because of one of the side effects is sedation. And so patients that are often having difficulty sleeping are placed on trazodone.
And is trazodone, does that share some of the qualities of what I refer to as SSRIs, even though it's not an SSRI, it shares similar qualities?
Yes.
Can you tell me what SSRI means?
Yeah, so that's a selective serotonin reuptake inhibitor, and it's a class of medications that are antidepressants.
And the SSRIs, that would also include Zoloft, for example?
Correct.
Would also include Prozac, for example?
Yes.
Are you as a psychiatrist aware that Zoloft and or SSRI Prozac should not be prescribed to a patient who has bipolar?
Yeah, it can be prescribed. Oftentimes it's prescribed together with another medication that can be protective because patients with bipolar disorder may be experiencing depression, and so they may be prescribed an antidepressant, but along with another medication that what we call protective.
And in reference to the SSRIs, the selective serotonin reuptake inhibitor, what does that mean, selective serotonin reuptake inhibitor? What does that mean?
Yeah, so oftentimes in depression, patients are kind of lacking serotonin in the spaces in their brain that helps.
Can I interrupt you? What is serotonin?
Yeah, serotonin is a neurotransmitter, so it's a hormone in the brain that works on the brain. It works in other areas in the body as well, but for these purposes, it works in the brain at nerve endings throughout the body. And that neurotransmitter helps with things like mood regulation. For patients with depression, they're often lacking kind of that ability to have enough serotonin in those spaces. And so a selective serotonin reuptake inhibitor prevents serotonin being kind of sucked back into the cell. So it allows for serotonin to be more available.
And what is an SSAI? What does that mean? Antagonist? Selective serotonin antagonist.
So those are medications that kind of do the opposite.
Okay. And you knew, as a psychiatrist, at least looking at her history, you knew that she had been seeing psychiatrists immediately prior to her suicide attempt, correct?
Correct.
And you knew that she had been prescribed a number of drugs by these various psychiatrists, correct?
Correct.
And to your knowledge, was she prescribed diazepam?
Yes.
Valium? Was she prescribed buspirone, otherwise known as Vanspar?
Yes.
How about Wellbutrin?
Yes.
And what is Wellbutrin? Is that an antidepressant?
It is an antidepressant.
Hydroxyzine. What is hydroxyzine?
It can be used for a number of reasons, but for psychiatric purposes, it's often used as an anti-anxiety medication.
And Klonopin.
Yes.
Is hydroxyzine, is that a, strike that. Klonopin, that's a benzodiazepam, right?
That's correct.
And then lamotrigine.
Yep, lamotrigine.
Lamotrigine, sorry.
Yes.
What type of medication is that? Is that a mood stabilizer?
It is, yeah. It's also an anti-seizure medication, but in the psychiatric realm, it's used as a mood stabilizer.
And then we talked about Prozac, that's an SSRI, correct?
Correct.
And what's Remeron?
Also an antidepressant.
So in addition to all of the drugs that I had mentioned, she was also prescribed Remeron, correct?
Correct.
She was also prescribed Seroquel or quetiapine.
Yeah, quetiapine, yes.
Quetiapine, okay. And what is Seroquel?
So Seroquel is an antipsychotic medication.
And she was prescribed, as we already talked, trazodone, Was she also prescribed amitriptyline?
Yes.
What is amitriptyline?
Amitriptyline is one of the older antidepressants. It's a tricyclic antidepressant that can often be used to help with sleep, but also mood.
And Ambien, correct?
Correct.
And Zolpidem.
Yep, Zolpidem is the generic name of Ambien.
Oh, okay. Some of these drugs, they also have what's called a suicide warning or a black box warning. Isn't that right?
Yes.
Can you tell me what that means?
Yeah. So in studies that have been done, some of them show that especially after starting an antidepressant, it can increase someone's risk of suicidality. Many of those studies showed that it was mostly in adolescents and young adults, but it can happen in adults as well.
And Celexa was also a drug. Is that an SSRI too?
It is.
And all of these drugs that we just went through were all prescribed from end of September till January.
Yes, September 2022.
4 month period.
Yes.
It's an awful lot of drugs to be prescribed in 4 months, isn't it?
Objection. Sustained.
Thank you.
Thank you.
Commonwealth redirect?
Yes. Doctor, all those drugs that defense counsel just listed, you're aware she wasn't on all of those drugs at the same time, correct?
Correct.
And did you know that many of those drugs she took a very small amount of? Some she didn't take any pills at all?
I was not aware of that.
For Busbar, which is one of the ones he mentioned, were you aware the first prescription she only took 2 pills out of that bottle?
I was not aware.
Were you aware the second prescription a month or so later for Busbar she took 0 pills out of that bottle?
I was not aware.
So where are you getting this information about what she was on and when?
Yeah, so one of the things that we do is try to collect as much information as we can during our assessments. And so we look through the record in terms of what was prescribed. We also talk with other providers as to what they prescribe. But in the context of the assessments that we were doing, it did not require us to determine, what exactly she had been on before, because we were using a different set of medications to treat something, different symptoms that she was experiencing.
Okay. So you really have no idea what she was taking or when? You just know what was prescribed?
I know what was prescribed, and then we were also getting reports of what was being taken, what wasn't being taken. But
from the defendant?
Correct.
Okay. So she's reporting to you that she took those medications, but you'd be surprised to know that at least one of them 0 pills were taken.
I don't think I'm surprised, no.
Okay. And you talked about prescription and what she was taking. Were you aware that in the time frame just prior to her being admitted to the hospital, she was only prescribed trazodone, Valium, and amitriptyline, just 3 medications?
Yes, I was aware.
And you were asked about mania and exercising and cleaning out your garage and selling your belongings could be signs of mania, correct?
Correct.
But there are people who just exercise every day and they're not manic, correct?
Correct.
And there are people who have a messy garage and have accumulated a lot of junk and decide to clean out the garage that aren't manic, correct?
Correct.
And in fact, if someone is manic and attempts to do one of those tasks like cleaning out a garage, it's usually in a disorganized way and oftentimes they don't finish the task, correct?
Sometimes.
So if someone approaches a task like cleaning out the garage by organizing with another party, organizing the belongings, separating them into keep, sell, throw out, that's pretty organized behavior, correct?
Correct.
And if someone sells belongings that they no longer need, that's not necessarily a sign of mania, correct?
Correct.
That's more if they're selling their stove and then they have nothing to cook with, correct?
Correct.
So if they're selling junk in their garage that they no longer need, that's not necessarily manic, correct?
Not necessarily.
Thank you.
Mr. Rington?
So if the person, as counsel said, they're exercising every day and they have a messy garage, that obviously would not be indicative of hypomania, would it?
Probably not.
A normal person could have, as counsel said it. How about a person that at the same time can't sleep because the insomnia is so bad they go 48 hours without sleep? Is that something to be considered in the whole evaluation?
Yes.
How about the fact of the person saying that my brain is broken and that they can't concentrate, they can't think. Is that something that the person you would consider in conjunction with the messy garage and the exercise?
Yes.
Thoughts of hurting themselves, suicidal ideation, that's something that's important to evaluate?
Yes.
Homicidal ideation, telling your husband that you're having thoughts about hurting your children, that's something you consider, isn't it?
Yes.
In reference to counsel's comment about just 3 medications that she was on prior to trying to commit suicide, you're not aware of the doctors telling her to discontinue this medication, start a new medication, go on to a different medication, depending on the doctor. You're not aware of that, right?
No.
And finally, if you know, did she sign a DNR, do not resuscitate?
She asked to the day after the first evaluation that I did of her, which was the capacity assessment to change her healthcare proxy. But in the context of her reporting a serious suicide attempt, we did not change her code status. We continued to chat with her about that, and she ultimately came to the conclusion that it made sense to make sure that her mental health was stable before she considered her code status.
Okay, but her initial reaction or her conversations with you all was that she wanted to have a do not resuscitate status.
Correct.
Thank you.
Como?
Nothing further.
All right, thank you, Doctor.
Thank you, Your Honor.
All right, members of the jury, we're going to take the afternoon recess at this point. So I'm going to ask you to go back to the jury room, and then we'll come back here approximately 2 o'clock. Okay?
Court, all rise. Sure, so the notebooks placed on the chairs, please.
Counsel, anything we need to address before the break?
No, Your Honor.
No.
All right, so we'll be in recess till about 2 o'clock. Thank you.
Thank you.
What? All right.
Jurors entering. This court's now in session. Please be seated.
Your Honor, for the purpose of the record, we return back to the trial of Commonwealth versus Lindsay Clancy. All parties are present, including the defendant and including the 18 jurors.
All right. Thank you, Madam Clerk. Commonwealth, you ready to call your next witness?
Yes, Your Honor. The Commonwealth calls Dr. Biswas.
All right. Good afternoon, Doctor.
Good afternoon.
All right. Commonwealth, please.
Thank you, Your Honor. Good afternoon. Can you please state and spell your first and last name?
Yes, my name is Jhilam Biswas. My first name is spelled Jhilam, last name spelled Biswas.
And your date of birth?
Date of birth is 9/12/1982.
What do you do for a living?
I am a forensic psychiatrist, and I work at Brigham and Women's Hospital.
And what is a forensic psychologist or psychiatrist? Pardon.
Well, I'm a forensic psychiatrist by specialty training, and we work in the courts often doing forensic evaluations of individuals, but I'm also an adult psychiatrist, and I work at Brigham and Women's Hospital as an adult psychiatrist on the consult liaison unit.
And can you just briefly describe your education and training background that qualifies you for this work?
Sure. I grew up in the South Shore. I went to Dartmouth College, and then I went to medical school at UMass Chan Medical School. I then did my psychiatry residency at Harvard Longwood, which consists of Brigham and Women's, Beth Israel, Boston Children's at the time. And after that, I did subspecialty training after my psychiatry residency in forensic psychiatry, again at UMass Chan Medical School.
And focusing in on January of 2023, were you working at the Brigham and Women's Hospital?
I was.
And specifically on January 25th, 2023, did you interact with a patient there named Lindsay Clancy?
I did on January 26th.
26th, okay. And in what capacity did you interact with her? As a forensic psychiatrist or as a member of the staff at Brigham and Women's?
I interacted with her as a member of the staff, the psychiatry staff at Brigham and Women's Hospital.
And did you have a particular role that day on January 26, 2023?
Yes, I was on the consult liaison service, which is the psychiatry service that's called by medical and surgical specialties to help evaluate and provide psychiatric recommendations.
And did you meet with Ms. Clancy on that day, on the 26th?
I did.
And was that around 2:14 p.m. that you had that interaction?
I think it was somewhere between 2 and 3 o'clock, yes.
And when you met with Lindsay Clancy, was that in her hospital room in the ICU?
It was.
And was she intubated at the time?
She was.
And was she awake?
She was awake.
And was she oriented?
So she was intubated, so it was difficult for her to really answer a range of questions, and so she gestured to me to be able to write. And so we knew that she was really exhausted and anxious from the entire experience and the evaluation, and so we didn't ask her all of the questions around orientation.
When she gestured that she wanted to write, did you give her something to write with or something to write on?
I did.
And what did you give her?
Paper.
And did you also give her a pen or something like that?
I did.
Okay. And was she able to when you asked her certain questions, was she able to answer those questions by writing the answers on the paper?
She was.
Okay. And did you ask her about her mood that day?
I did ask her mood.
And what did she write?
She wrote horrified.
And what was her affect during this interaction?
At the time that I saw her, she was intubated, and that in and of itself is very uncomfortable, and so she seemed very anxious.
Okay. And did she write anything else on that paper that you saw?
Yes, the entire evaluation was done through writing because she couldn't speak.
So what types of questions were you asking her, and what was she responding with?
So we asked her, how are you feeling? Horrified. And then she wrote down, do I have an attorney? And I said with my team that at this time, we're just getting to know you and getting to know the case, and we're not sure exactly, what is happening. And we asked her, do you have questions for us? And she asked, is my body broken? Are my legs straight? And she then asked about, can she have visitors? And, where her family is.
And when you are asking her questions, what is the goal of the questions that you're asking her? What are you trying to address or assess?
It depends. Psychiatrists are called for all kinds of issues that happen in the hospital. In this situation, we were asked around, diagnostic clarity, that there was a likely suicide event that occurred. Can you evaluate her for safety at this time before she goes into surgery?
And I know that she was intubated, so she's writing her answers. But based on the answers she wrote on the paper, did she seem to understand the questions you were asking?
Yes.
And her responses, did you understand those?
Yes, she was anxious and she needed breaks, and I said, anytime you need a break, we can leave. But she did write to us those particular answers.
So what she was writing, even when she asked if she had a lawyer, those were things, what she was writing made sense given the situation. She wasn't writing, is there a unicorn in the corner, right?
Correct.
Like that.
What? I'm sorry, I didn't hear that. What?
If there was a unicorn in the corner. So what she's asking, do I have an attorney? Are my legs straight? Is my body broken? Those all made sense given the situation she was in, correct?
They were relevant answers and questions she was asking.
Okay. And are you familiar with the characteristics of psychosis?
Yes.
Okay. And what are the typical signs or symptoms of someone who is in psychosis?
It really depends, and it ranges across a spectrum of symptoms. So we have a whole category of different types of symptoms that we look at for psychosis, and they are different for everyone. But, they can be what we call negative symptoms, which are more internal, isolating, not responding, not reacting very much. And then we have symptoms like positive symptoms, that's what we call them in psychiatry, but they're a little bit more outward focused, where objectively you can see what those symptoms are, like being paranoid, darting your eyes around, responding to internal stimuli, which means you're responding to voices, and, being within a delusion. So there's all kinds of symptoms, and they look different for each and every person.
In your conversation with Ms. Clancy, did you notice any internal or external signs of psychosis?
At the time, I documented that I did not note those.
Okay. And did you also note that, she was, her thinking was linear, goal-oriented, thoughtful, and she didn't appear to be responding to internal stimuli?
Yes, that is typical language in psychiatric mental statuses, and I did document that.
What is internal stimuli?
Oftentimes, it's very difficult for our patients to be able to articulate what they're hearing. They may have perceptual disturbances like hallucinations or auditory hallucinations and maybe hearing voices. When it's really active, we often see those individuals interacting with those voices. I didn't see that in that particular moment.
So, for example, you could see someone engaging in looks like they're engaging in a conversation with someone, or looks like they're looking over at something, thinking something or someone is there when they're not. Is that
correct? That's what responding to internal stimuli is. Yes.
And you didn't see any of that present with Ms. Clancy?
Correct.
Okay. And would it be fair that some of the obvious signs of psychosis would be someone whose thoughts are disorganized, that their thinking isn't linear, that they're not making sense, things like word salad where they're just throwing in words, making sentences that don't make sense?
So you describe symptoms that we can see in people with serious mental illness who have a psychotic disorder with active symptoms.
And you didn't see any of that with Ms. Clancy, is that correct?
Not in that snapshot moment of time.
Right. And to be clear, you only saw her for a limited amount of time on that one day, correct?
That is correct.
And this is January 26, 2023, about a day and a half or so after she's admitted to Brigham and Women's.
That is correct, yes.
And she's still intubated.
Yes.
And one of the first questions she asked is, do I have a lawyer?
Yes.
And did you have any, based on your training experience, did you have any thoughts about her awareness or thoughtfulness about the questions she asked or the answers she gave?
I don't know what that means, objection.
Okay, if you could rephrase that.
Did you have any assessment professionally of the responses and awareness that she had?
Yes, at that time, I was trying to assess, is she confused or oriented? Is she completely disorganized? Is she so anxious that she won't be able to sleep? I was assessing suicidality mostly. I was being called into the room for that. And so there were a lot of things that I was assessing all at the same time before the surgical intervention that was going to happen. And did I answer your question?
Yes. Okay. All right. And so in doing that, in evaluating all of those things, did you have any concerns at that point in time that she couldn't make a decision to have the surgery, or that there was some cause for concern there in her behavior?
I felt she had the capability to make the decision for surgery at that time.
I have no further questions. Thank you.
Thank you.
Yes. Mr. Reddington.
Good afternoon.
Good afternoon.
So just a couple of questions. Counsel was asking you about psychosis. Apparently you've dealt with people, some of your patients, while you're working in the hospital that in fact were florid. They had psychosis and symptoms of psychosis?
Yes.
So you've dealt with people, is it a fair amount of people that would actually hear voices?
Yes, I've seen many patients that are hearing voices.
And were they, to your knowledge, were they involved with command hallucinations, things of that nature?
My patients in the past?
Yeah.
Yes.
Yeah. A fair large amount of people that you've treated over the years that have suffered from command hallucinations, hearing voices, delusions, things of that nature, right?
In my career, yes.
Yeah. And do you know whether or not there had been any indication from Lindsay as to, well, in the hospital, having any delusions or psychosis symptoms of that nature, if you know?
So I saw her, she had only been in the hospital for a day and a half.
Right.
And I hadn't heard about any psychotic delusions
and that's
from anybody.
what you saw, though. I mean, as far as you, like, how often would you see her?
I see. I saw her one time.
Once. Okay. How long were you evaluating her?
Probably because she was intubated, it was
just asking how long.
About 20 to 30 minutes.
20 minutes, 30 minutes? And a psychosis, is a psychosis, to your knowledge, something that has to continue, or does it stop?
It absolutely depends on the patient. It depends on their age, how many episodes of psychosis they have had. It depends on the type of psychosis we're seeing. For some people, they can have moments of clarity, absolutely, and for some, it can be more continuous. It really depends on the patient and their illness.
Okay. So basically, you're saying that it would be case-specific?
Yes.
All right. And in the 20 minutes or so that you had when you're dealing with Lindsay, were you aware of her prior medical and psychiatric history?
When we get consulted on a case,
I'm sorry, I didn't mean to interrupt you. I'm asking, were you aware of her medical and psychiatric history?
I was aware of the portion that was in the medical record before I saw her.
Okay, so that would deal with, as far as postpartum psychosis?
Could you ask that question again?
When you looked at the medical record and when you were involved evaluating her on behalf of the hospital, because you weren't a psychiatrist that her mother or father had retained and asked to go see her, right?
Correct.
You were working for the hospital.
I was working for Brigham and Women's Hospital.
And you had spoken to a number of people before you interacted with her for the 20 minutes that you saw her while she was there for a month, right?
No.
Okay. Now, were you aware of her history of documented postpartum depression?
I was aware of mostly the postpartum anxiety that was in the record, yes.
And postpartum anxiety, the symptomology would be insomnia?
Yes,
and
can be.
Did she have insomnia prior to seeing you for 20 minutes?
Yes.
And do you recall the length of time that she would be suffering from insomnia? Was it like a week, a day, a month, or what?
I don't recall the timing exactly.
Do you recall that at one point that she was on medication and actually went for 48 hours without sleep?
I don't recall that exactly from the record, that number.
Do you recall, in addition to the insomnia, that she was concerned as asking you if, in fact, her brain was broken?
She asked me, is my body broken?
Okay. Did you see in the records that she was concerned about the effect of the drugs and whether or not her brain was broken, quote unquote?
I did not see that language in the records.
How about acting on command hallucinations, conversations or statements to the effect that she was having thoughts of suicidal ideation? You knew that, right?
I did know about the suicidal ideation, yes.
How many times did she express to people that she would tell people that she had been concentrating on committing suicide? If you know.
I don't recall the number of times.
So in any event, you know that she was insomnia, you know that there was a significant period of time that she was suffering from insomnia, you knew that she was expressing suicidal ideation. How about homicidal ideation? Did she express that?
Not from my review of the records.
Okay. Would that be indicative of a person that could be in psychosis expressing concerns about homicidal ideation?
Objection. No. Overall, allow it.
Sorry, I don't know that question. Could you repeat that question?
Sure. Is that one of the factors that one would be concerned about as a psychiatrist if a person was expressing homicidal ideation?
I would be concerned about that as a psychiatrist.
And in fact, in this case, you knew at least about the suicidal ideation that she had been expressing, right?
Yes.
But you didn't know about any homicidal ideation she was expressing, right?
From the records or
prior to coming to see you for 20 minutes?
I knew that there was an event that had occurred and that
3 children died. That's the event you're referring to, right?
Yes.
Okay.
Right. Next question.
Now, as far as the period of time that she was involved with, by the way, what's hypomania?
Hypomania is sort of the gradual increase towards mania, the symptoms that we see in somebody who might have bipolar disorder. And with bipolar disorder, we see mixed depression, and we see mania, and we see symptoms that kind of gradually increase to mania, and we call that period hypomania.
Did she exhibit, to your knowledge from the medical records, any periods of hypomania? Excessive cleaning, exercise, or activities, being awake at night, things of that nature?
At that moment, on January 26th, I don't remember reading about that.
Okay. Do you have any memory of reading about it at all, other than that moment? As a treating physician, a doctor, a psychiatrist?
I don't remember.
So what is your purpose at the hospital? I mean, you're not treating the person for any illness that they have as far as their mental condition, right? You're not treating them.
We are.
Oh, you are?
Yes.
So you're concerned about, obviously, their symptomology, if any, that they present at the time that you're looking at them and talking to them, or in this case, she couldn't talk, but
she couldn't talk, and she was going into surgery, and we had recommended suicidal precautions. We had recommended trauma-informed care so that she was getting the care that she needed. She was going to go into surgery. And then, after that, we were going to continue to follow her and assess her and make sure that we were evaluating her appropriately and making recommendations to the surgical team for the care that she needed.
You all set?
Objection.
So, when you're dealing with this person that's going into surgery, did you know what type of surgery she was going in for?
At the time, we knew that she was going into surgery for her spine.
Did you know what happened with her spine?
I knew that she had injuries to her spine.
Did you know that there was a transection injury, that her spine was basically exploded in T5, T6? Other thoracic vertebrae fractured, including the cervical vertebrae up by her throat. You knew all that?
We were reading about it. It was all actively happening at that time.
Was she in pain?
Yes, I'm sure she was.
Was she on medication?
Yeah, she was on a few medications related to pain and blood pressure.
So she's brought into the hospital. You knew from reviewing her records as a psychiatrist that, in fact, she coded the day before, right?
I don't recall her coding the day before I saw her. I do recall from the records that she had a coding event after, I think on the 27th or 28th.
Okay, so you were not involved with her when she coded. Did you know that she had any events of that nature right after she was brought from the South Shore Hospital?
I don't know what you're referring to.
You know what a code is, right?
Yes.
Did she almost die before you saw her?
I think it was after.
Okay. How about perfusion, blood in the body and tubes being inserted into her chest? Did you know that from looking at the records?
I think that happened after, but I don't recall because I don't have the records on me.
Okay. So did you know that she had massive transfusions?
Not at the...
On this jury that it was after she saw you that she coded, had transfusions, had double tubes put into her both sides of her lungs? It's your testimony that it was after she saw you? You don't know, do you?
My understanding is the surgery happened after I saw her.
Oh, the surgery did. I'm asking you about the massive transfusions. I'm asking you about the tubes being inserted so that the 300 milligrams or whatever it is of blood can be perfused or taken out of her chest cavity. I'm asking about whether or not you knew that she had coded. I'm not asking about the surgery. Obviously, that took place after you saw her, right?
Objection asked and answered.
No, overruled.
Because that's why you were talking to her, right? To see if she could make an informed consent to a surgery, I guess.
No, I was called for the suicidal ideation.
Okay, I'm sorry. I thought you said that you wanted to talk to her about the surgery as well.
No.
The suicidal ideation continues to this day, does it not?
Objection.
Sustained.
Did the suicidal ideation that you were concerned about continue the time that she was in Brigham and Women's Hospital for a month?
I saw her one time.
Right, I know that, 20 minutes, right?
Yes.
Okay. So you know nothing about suicidal ideation after you saw her intubated and then laying in the bed, and then you talked to her as you've discussed with the jury, right?
That's correct.
That's it?
That's correct.
How about the cops? How many cops were there?
I don't recall.
There were some, right? There were armed men in that room, were there not?
I don't recall. I think they were outside the room, if I remember correctly, from 3 years ago.
Okay, I know it's been a while. Do you recall armed police officers being outside the room?
I think I don't recall.
Do you have any memory of any police officers being outside the room where she was laying in that bed?
I knew she was in custody, and generally in custody...
No, not generally. Let's talk about Lindsay Clancy.
I can't recall.
Okay. Did you know that she couldn't even have visitors in the sense that the police would not even let her mother or father visit with her?
I can't recall.
Did you know that when you were dealing with her, was she handcuffed to the side of the gurney of the stretcher?
She had a soft restraint, according to my documentation.
Soft restraints, okay.
Yes.
Did you have any conversation with the police at all?
No.
And after you spoke to her for 20 minutes, that really ended your involvement with Lindsay Clancy until today, right?
That is correct.
Okay, thank you.
Thank you.
Redirect.
Doctor, when you were being asked about these records that you reviewed, what records did you review?
I reviewed the records in EPIC, which is our medical record at Brigham and Women's Hospital.
And so you didn't do a deep dive into Ms. Clancy's entire psychiatric history prior to coming to Brigham and Women's, correct?
I did, as you do, as is protocol for a consult, you look at the records and you make sure you have an understanding of what's been happening with the patient.
But did you have access at that time to all the records for all the treatment providers Ms. Clancy had seen regarding her mental health for the last 6 months?
You know, I don't even know. I had some of the records. I don't know if I had all of the records.
Okay. And so you reviewed what you had, correct?
Correct.
And then you met with the patient, correct?
Correct.
And in meeting with her, where she's had these events happen. She's had the tubes in her chest. She's about to go into surgery. One of the first things on her mind is, do I have a lawyer? Correct?
That move to strike that. First of all, it wasn't part of cross. Secondly, this is the fourth time the counsel has tried to accentuate that.
Well, I'll allow that question. Go ahead.
Well, that was one of her first thoughts was, do I have a lawyer? Correct?
She wasn't able, she was exhausted. She was intubated. She could barely talk. She was writing and she was getting ready for surgery. And so those were the few questions that came up.
Right. She's exhausted. She's anxious. She's in pain. She's about to go in for surgery. And she wants to know, do I have a lawyer?
Sustained.
So given the condition she was in at that time, the defense counsel asked you about the pain she was in. Defense counsel asked you about the surgery she was about to go into. Those are the issues that she was focused on.
Yes.
In your conversation with her, am I broken? Are my legs straight?
Yes.
Do I have a lawyer?
Yes.
Thank you.
She wasn't focused on much while she was exhausted, in pain, anxious, and concerned about the future surgery that she was imminent, was she?
If you could speak up, ask that question.
Sorry. She wasn't focused on much of anything while she was exhausted, in pain, unable to talk, and anticipating imminent surgery, right?
That's correct.
Thank you. That's all I have.
Anything, Coma?
No.
All right, thank you, Doctor.
Thank you. Thank you.
All right. Coma?
Commonwealth would call Robert Flynn as its next witness, please.
All right, good afternoon, sir.
Good afternoon, Your Honor.
Yeah, Attorney Buckingham, please.
Thank you. Good afternoon. Could you please tell the jurors your first and last name?
Robert Flynn, Flynn.
And how are you employed, sir?
From the Duxbury Police Department.
What is your current rank or assignment there?
Currently, I am a patrol sergeant.
How long have you been with the Duxbury Police?
About 7.5 years.
Going back to January of 2023, what was your assignment then?
I was assigned to the Detective Bureau.
So if I draw your attention to January 24th of 2023, were you working that day or were you called in?
Both. I worked the 8 a.m. to 4 p.m. shift, and I was called in later after my shift.
Okay, so you became aware of an incident that occurred in the town of Duxbury approximately 6 p.m. that evening?
Yes, ma'am.
And so when you come back in after working that day shift, where do you go or where are you directed to go?
I was contacted by Sergeant Detective Jamali, who informed me to respond to 47 Summer Street.
And so while you're en route to that location, are you monitoring the radio?
Yes, ma'am.
And are you monitoring communications with other Duxbury officers?
Yes, ma'am. I had a department-issued vehicle that I took home, and I responded to it in that vehicle, and I had a scan on, which is getting all surrounding agencies, including fire, Pembroke, Kingston, Marshfield.
And while you were en route and had that radio on, could you hear officers screaming and it being chaotic?
Yes, ma'am.
When you arrived at 47 Summer Street, were there already other first responders there?
Yes, ma'am.
And is it fair to say that when you actually arrived at that location, you were made aware that the children that were on scene had already been transported?
No.
Okay, so what did you know when you arrived? What did you
I knew that there was an incident involving children. I learned that when I initially responded and spoke to Sergeant Homestead. He was the one that informed me that it appeared that a mother had killed her 3 kids.
Okay, but when you got there on the scene, were the children still in the house?
So I was under the impression that they were still in the house because most incidents I've had involving a sudden death at a house, the fire department declares them on scene and it becomes a police matter and we help with the investigation.
Okay, that was your understanding based on the information that you had, correct? But did you come to learn that the children had been transported?
Yes, ma'am.
And how about the individual, the person, the fourth person, if you will, on scene? Were you advised that there was a woman who had been transported from the scene as well?
Yes, ma'am.
And as a result of kind of the nature of what you believed you were coming into, did you call for extra help?
With our own department or?
With an outside department?
Yes. So the Massachusetts State Police has jurisdiction over any death investigation in the town of Duxbury and other communities. So we are to notify investigators of the state police.
And as a detective at the Duxbury Police, you're familiar with that relationship with the state police, that oftentimes when a death investigation occurs, that you work in connection with the state police detectives unit of that jurisdiction to conduct an investigation, correct?
Yes, ma'am.
And so in this instance, when you went there, you believed that the children had already passed, so you made that phone call to the detectives unit, correct?
That's correct.
And certainly, sometime thereafter, you were advised of the children's passing and that this was a death investigation, correct?
That's correct.
Once the children had been removed from the scene and the defendant had been removed to the scene, did you and your other officers from the Duxbury Police Department do anything to secure the scene?
Yeah, so once we gathered more information and I notified the Massachusetts State Police, we decided to conduct a security sweep of the house. This is to make sure that there was no further suspects or further victims or any other people in the house that we may have missed.
In regards to this security sweep, what is the goal? You just described it to kind of identify if there are other people, but as far as your observations and your contact within the house, do you try to minimize your contact within the house in those instances?
Yes, I'm not searching for any type of evidence. I just have different observations that I obviously notice.
And what areas of the house did you go into prior to the arrival of the state police? I entered with three of us. Sergeant Patricus, who's from the Kingston Police Department, and it was Lieutenant Weiler at the time. So we all kind of went into our own separate rooms and separate ways throughout the house. But I think ultimately all three of us went to all 3 floors of the home. Okay, and so talking first about the main floor of the house, did you go into the kitchen area?
Yes, I did.
And did you make any observations in that kitchen area?
I observed, it was clear to me that there was young children living there. There was some paintings on the wall. I noticed a takeout food bag. The only word I remember from that is it being Mediterranean, written on the receipt.
Okay. And if I may approach with a picture. Showing you the picture just accurately depict the kitchen area that you observed.
Yes, ma'am.
I'll move to admitted.
That may be admitted.
Just kind of showing you on the screen what's now been marked as Exhibit 44. This is the kitchen at 47 Summer Street, and in the middle of the photograph is a takeout bag, correct?
Yes, ma'am.
And you're aware that in the background here of the photograph where there's a kitchen table, there's kind of a door next to it.
Yes, ma'am.
And then there's, on the other opposite side, there's a slider door, correct?
Correct.
And in addition to making those general observations about the kitchen area, did you go in other areas of the main floor of the house?
Yes, I did.
And in the living room area, I'll show you what's been marked already as Exhibit 25. Is that familiar to you as well?
Yes, ma'am.
And again, upon your kind of sweep of this house, what stood out to you about the living room area?
There appeared a young child lived there, and there was food on the couch, a snack.
And in this photograph, can you see a couple of bowls, a bowl here on the bottom of the photo and a bowl further up on the couch?
Yes, ma'am.
Now, in that main area of the house, you didn't find any other individuals, correct?
Negative.
And had you been made aware that the husband, Patrick Clancy, had been on scene and he had also been transported from the area?
Patrick Clancy was on scene when I was there.
Okay. At some point, did he go in an ambulance?
Yes.
Okay. Now, in that second floor of the house, let me ask you, what's the next area of the house that you recall going through in this sweep?
Into the basement.
Now, were you advised that things had occurred in the basement?
I think so. I'm not really.
Okay. And fair to say, this was still, upon your arrival, a pretty chaotic scene.
Correct.
There was a lot of firefighters around, a lot of equipment going around.
Correct.
Okay. In that basement, did you do a full sweep of every room in the basement?
Like I said, 3 of us combined and made sure that we at least hit every part that a human or something could be in. So, yes.
Okay, but as far as you yourself, fair to say you just kind of went in on the left side?
Yes, I went into the left.
And did you see a lot of the firefighters' equipment still left behind?
Yes.
A lot of medical supplies?
Yes, ma'am.
Now, going up to the second floor, did you go to the second floor of the home?
The top floor?
Yes.
Yes.
And did you enter into the master bedroom?
Yes.
And is there anything that kind of struck you about walking into that master bedroom as far as the temperature of the room?
It was colder than the rest of the house.
And did you notice that there was, in fact, a window open?
Yes, ma'am.
So I'm just going to show you what's been marked as Exhibit 43. Is that familiar to you as the window that you observed open?
Yes, ma'am.
And as far as the furniture in that bedroom, did you make any observations of a bed in the room?
Yes, ma'am.
Was there anything that stood out to you on the bedding or in the area of the bed?
The bedding itself?
If it stood out to you?
Not necessarily, no.
How about the items on the bed?
Yeah, so Sergeant Patrick pointed out that there was a cell phone on the bed.
Okay, I'm just going to show you. It's already been marked as Exhibit 42. And see, there's an object. Is that how it appeared when you first entered into the bedroom?
Yes, ma'am.
The phone. At some point, were you able to go out to the backyard of the home?
Yes, ma'am. So after leaving the upstairs, we went back through the kitchen, and that's what we talked about earlier, and went up through the back slider.
And were you able to make observations of the backyard area?
Yes, we came up to a porch and took a left, which would have been the back right side of the house. And there was some matted down snow and some other medical equipment, which we believed was the window that Lindsay Clancy came out of.
And from that area or that vantage point in the backyard where you were, could you see into other areas of the house?
Yes.
And what areas of the house could you see into?
Near where that area was, there was a basement window that kind of went into, but I later learned what it was, but a basement window to like an office or gym area.
Show you Exhibit 38. Is that familiar as the backyard view?
Yes, ma'am.
And fair to say there's an area here of the photo that I'm pointing to with my pen, which is kind of on my right. That is a window well. Is that the window you could see into?
Correct.
And then again, in this photograph, do you see the open window that you observed when you went into the bedroom?
Yes, ma'am.
As far as that open window, when you were in the backyard, did you see any screens or anything around the property that would give you any indication of how that window was open or the condition of the window?
No, to me it appeared like the screen was just pushed up.
Now again, as you and the three other investigators did that sweep of the house, you didn't touch or move anything, correct?
Negative.
And once you did that security sweep, is there a protocol in place to make sure that the scene remains as it is until the state police arrive?
Yeah, so there was one of the officers was logging individuals that were in and out of the house. Crime scene tape was put up around the property. The doors were secured, and around this time is when I received a phone call from Trooper McKellican.
Okay. And did you remain on scene?
We remained on scene until some troopers showed up to the area.
Okay. And while you were on scene, did you attempt to help coordinate other members of the Duxbury Police Department to take care of other things like going to the hospitals and securing coverage?
The decision for who was going to the hospital was made by our command staff, but I met some of the troopers back at the station to coordinate further.
Okay. And when you were back at the station, were you aware or advised that a search warrant was sought for the residence?
Yes, ma'am.
Did you go back to 47 Summer Street with the team when the search warrant was received?
Yes, ma'am.
And did you participate in the execution of that warrant?
I was present during it.
Okay. Fair to say, though, you didn't, you weren't responsible for searching any particular location or collecting any evidence?
No, ma'am.
That was reserved for the state police?
For the most part, yes.
At the conclusion of that search warrant, were you asked to go back into the house?
Yes, ma'am.
And what were you asked to go back in the house to do?
Once the search warrant was completed, my lieutenant told me to go back up into the house and close the window in the upstairs bedroom.
And when you went back and got closer to that window, did you make any observations of damage to the window or the window screen?
No.
And were you able to close it and secure the window?
Eventually, yes.
Fair to say there was blood in that area that kind of was in the way?
Yes, and the bed was kind of pushed in front of it.
Okay. So did you have to move the bed in order to get to the window?
Yes, ma'am.
As far as anything removed from the home, did you go back into the basement at somebody's direction?
No, ma'am.
At some point, had you helped to remove some medical equipment that the fire department had left behind?
That was during the search warrant.
Okay. And is that the only items that you yourself removed from the home?
Correct.
As part of the follow-up investigation, did you work with Trooper McGilligan and some of the other troopers from the State Police Detectives Unit to conduct follow-up interviews and gather more information?
Yes, ma'am.
Is it fair to say that the state police were the primary investigators and they took over pretty much everything from that point on?
That's correct.
I have nothing further. Thank you.
All right. Mr. Reddington.
I have no questions. Thank you, sir.
All right. Thank you, sir.
Thank you.
Commonwealth calls Mark Farioli.
Good afternoon. Do you solemnly swear that the testimony and the evidence you shall give to the court and McDonough between the Commonwealth and the defendant shall be the truth, the whole truth, and nothing but the truth, so help you God? Thank you, sir. You may have a seat.
All right. Good afternoon, sir.
Afternoon, Your Honor.
Honey?
Yes,
Thank you.
please.
Good afternoon. Can you please state and spell your name for the record?
I'm Detective Mark Farioli, Farioli.
Where do you work?
The Massachusetts State Police.
How long have you been a state trooper?
Since 2005.
And back in January of 2023, where were you assigned within the state police?
I was assigned to the Plymouth County State Police Detective Unit.
And were you involved in a limited way in the investigation regarding Lindsay Clancy?
Yes, I was.
And specifically directing your attention to January 27th, 2023, were you aware that a search warrant was obtained on that date to collect the blood and urine of Lindsay Clancy from South Shore Hospital?
Yes, I was.
And then directing your attention to January 31st, 2023 at 10:25 in the morning, did you go to the South Shore Hospital to collect the blood and urine of Lindsay Clancy?
Yes, I did.
And where did you collect that from?
The lab at South Shore Hospital.
And was that from the specimen process supervisor, Melissa Arkadepane?
Yes, it was.
And do you recall how many vials you collected?
In total, I collected 7 vials.
And was that all blood or urine or both?
6 were blood vials and 1 was urine.
And once you collected those vials, where did you bring them?
I brought them directly to the Massachusetts State Lab in Lakeville.
And did you drop those off at the state lab at approximately 11:15 a.m. on January 31st, 2023?
Yes, I did.
And do you recall who you gave the vials of blood and urine belonging to Lindsay Clancy to at the lab?
Leah O'Connell.
Thank you.
Mr. Reddington?
We have stipulated to the chain of custody for the blood.
All right. Any questions?
No, I don't have. Thank you, sir. I have no
All right.
questions.
All right. Thank you.
Thank you.
Leah O'Connell.
Good afternoon. Do you solemnly swear that the testimony and the evidence you shall give to the court and the jury and McDonough and welcome the defendant shall be the truth, the whole truth, and nothing but the truth, so help you God? Thank you. You may take a seat, miss.
Watch your step, please.
Hi, good afternoon.
Good afternoon, sir.
Hi. Counsel?
Thank you. Good afternoon. Can you please state and spell your name for the record?
My name is Leah O'Connell, Leahoconnell.
Where do you work?
Currently, I'm employed with the Massachusetts State Police as a trooper.
Back in January of 2023, were you also employed with the State Police?
I was at the crime lab.
And what were your responsibilities at the crime lab at that time?
So I was a forensic evidence technician, so we would receive evidence submitted to the lab for testing.
And once you received that evidence at the lab, well, first of all, who would you receive that from? Would that be chemists? Would that be troopers? Who would it be from?
It was local, state, sometimes federal agencies, but there was also scene evidence gathered by chemists that we would have to log into the system.
And so would it be your responsibility to take that evidence, log it into the system, and move it along for a process through the lab?
Yes.
And were there tracking numbers or lab numbers that you would assign to evidence in order to keep track of it as it progressed through the lab?
Yes, every case gets its own number.
And directing your attention to January 31st, 2023, at 11:15 a.m., do you recall receiving 6 vials of blood and 1 vial of urine belonging to Lindsay Clancy from Trooper Mark Ferrioli?
I did.
And when you received those items, did you log them appropriately into the system with her case number?
I did.
And how were they stored after that point?
So they go into a heat-sealed pack. So it's like a plastic bag that gets heat-sealed, initial and dated, and then it goes right into a fridge.
Okay. Thank you.
Attorney Reddington?
I have no questions. We stipulate to the blood, so.
Okay. All right, well, thank you. You may step down. Thank you.
Commonwealth calls John Santos.
Good afternoon. Raise your right hand to the clerk.
Good afternoon. Do you solemnly swear that the testimony in the evidence you shall give to the court and the jury in the matter not having between the Commonwealth and the defendant clash and the truth and whole truth?
I do.
Okay, sir. You may have a seat.
Watch the step, please. Step.
All right, good afternoon, sir.
Good afternoon, Your Honor.
Attorney Sprague, please.
Thank you. Good afternoon. Can you please state and spell your name for the record?
Good afternoon. My name is John Santos, JOHNSANTOS.
Where do you work?
The Massachusetts State Police.
And what department are you currently in?
I'm assigned to the Division of Investigative Services.
And back in January of 2023, what was your assignment?
I was assigned to the State Police Detective Unit in Plymouth County.
And were you, specifically on January 24th, 2023, were you part of a search warrant team at 47 Summer Street in Duxbury?
Yes, I was.
And what was your role in terms of where you were assigned to search within the home?
I searched multiple locations to include the basement, the kitchen area, and then the master bedroom on the second floor.
Okay. And specifically directing your attention to the kitchen area, did you search a cabinet in the kitchen above and to the right of the stove?
Yes, I did.
Showing you a photograph. Is this a clear and accurate depiction of the items you found in that cabinet on January 24th, 2023?
Yes, it is.
You could have this photo marked as the next exhibit.
All right, that may be admitted. Maybe admitted.
145. Thank you. Showing you exhibit 145 on the screen here. Focusing your attention on the top shelf, there were several notebooks and books that were seized. Is that correct?
Yes.
Were those taken out of the cabinet and cataloged by the state police?
Yes, they were.
Show you 5 items. If you could just look through these and let me know if these were the items that were taken.
We'll stipulate that those are the items that were in her kitchen. Okay.
If I could have these marked as the next 5 exhibits, please.
Do you want that 5 separate, 5A through?
5 separate.
Okay.
Please.
All right, thank you.
And sir, showing you what's been marked 146. So does it appear to be discharge paperwork from McLean Hospital for Lindsay Clancy?
Yes.
And this discharge paperwork on the 3rd page included a list of medications. Is that correct?
Yes.
So we have lorazepam 1 milligram, melatonin 5 milligrams, and trazodone 50 milligrams, correct?
Correct.
Along with description of when she used to take those medications, correct?
Correct.
There's also instructions on the 6th page in about resources for therapy and community services, correct?
Correct.
And then Exhibit 147 is a notebook. Inside, it had postpartum depression and anxiety patient information sheet, correct?
Correct.
And then a detailing of different medications and the amounts taken and the dates they were taken, correct?
Yes, correct.
Then there was the book, Good Moms Have Scary Thoughts, item 148, correct?
Correct.
And then 149, a postpartum, pregnancy and postpartum anxiety workbook, correct?
Correct.
And nothing is filled out in this workbook, correct?
Correct.
And then finally, Exhibit 150, a notebook labeled Callan Patrick Clancy, correct?
Correct.
And inside this were messages back and forth between Lindsay Clancy and the nanny, correct?
Correct.
Now, you mentioned that you searched several rooms in the home, correct?
Yes, correct.
How do you divide that up? How is it decided who's going to search where when you're doing a search like this in a home?
It's somewhat fluid. We try not to send too many people in one room at a time because we end up tripping over each other to a certain extent. So, Usually it's kind of as we go along because we don't have an idea of what the layout of the house is before we get there, so it's difficult to plan that. So the supervisors who are overseeing the search will direct different troopers or investigators to search different rooms.
And so you said you searched the kitchen area, correct?
Yes.
Were you present when prescription medication was found in the kitchen, or had you already moved on?
I don't recall the medication being found while I was there.
And when you search a room, are you the only one searching, or are there other team members searching different parts of the room, kind of a divide and conquer?
Exactly, that's how it is. We divide and search different sections of the room.
Okay. And you said you went to the basement area. Do you remember what side of the basement you searched?
I was in the office portion of the basement.
Okay. And had anyone already been in that room, or were you the first to go in, or did you know?
I believe somebody had already been in that room when I made my way down there. I don't recall who was in there, but I don't think I was the first person to make my way in that room.
And you didn't collect anything in that room, correct?
I did collect some items
okay.
in the office, yes.
What items did you collect in the office?
There was, I believe, 2 laptop computers and a external hard drive.
And so you collected those items from the office. And when you do a search warrant, is there one trooper assigned to keep track of everything that's found, where it's found, who found it?
Yes, there is.
Okay. And so do you recall who that person was in this case?
I don't recall, no.
But when you do find something, is it you bring it to that person and they kind of log it and then you move on and keep looking for other things?
Normally the evidence officer would come down, we assign them and label them the evidence officer for each search warrant. They would come down to the area where the item was being recovered from, and we'd also have crime scene services photo the item in place as well before it was collected. So the evidence officer would come to us.
Okay, so for example, with the laptops, photos would be taken of them in the office, and then they would be logged, and then they'd be taken out of the office.
Exactly.
And is that what happened with the books and the notebooks that we discussed earlier?
Yes.
And you said that you then went up at some point to the main bedroom, the master bedroom?
Yes.
And what did you do inside the master bedroom?
I assisted with searching the master bedroom. I don't believe I recovered anything within there.
Do you recall ever looking in the nightstand drawer or anywhere near the nightstand by the open window?
I don't believe I did, no.
Okay. And is there any reason why you wouldn't have gone into that drawer or looked in that drawer?
Somebody else was probably already searching that area, would be my guess.
What area did you search in the bedroom?
I believe there was a closet. When you walk into the bedroom, I believe there was like a closet area to the left. I was in that area. And then I made my way at some point, to the left side of the bed as well.
And did you find anything in the bedroom of note?
No.
Now, when you're doing a search warrant, right when an investigation happens, how do you know what to look for?
Well, it depends on what you're investigating. This case specifically, we knew the facts what we knew at that time. So, I mean, when I noticed those notebooks in the cabinet, certainly I thought that information was pertinent to this investigation based on what we knew. But every investigation is a little bit different. The facts are different. So, yeah. I mean, clearly you want to look for items that relate to the suspect, victims, or any associates of them, and it might relate to the incident that's being investigated.
When the search was being done in the home at 47 Summer Street that night, did officers already know that Ms. Clancy had crushed up pills and taken them with lemonade?
No.
Okay. Had you learned from Patrick Clancy, the husband, that Ms. Clancy had been prescribed some medication?
I did, yes.
Okay. And were you aware at some point that medication was found in the kitchen?
Yes.
Okay. I have nothing further. Thank you.
Thank you.
Mr. Reddington?
Who found the medication in the kitchen?
I don't recall, sir.
It certainly wasn't somebody randomly off the street. It was a cop, right?
Yeah, a police officer or investigator, sir. Yes. Well, we had some local officers there with us as well.
Yeah. So it was law enforcement that found the pill bottles in the kitchen, right?
I believe so.
and seized them. Is that correct?
Correct.
And documented that they had seized them in the kitchen, feeling someone, whoever it was, that it was relevant material to this investigation, right?
Correct.
And the books that we've just gone through, someone felt that a notebook captioned Callan, Patrick Clancy would be relevant material to this investigation, right?
Correct.
Right?
Yes.
Along with the pregnancy and postpartum anxiety workbook, right?
Correct.
Along with the good moms have scary thoughts, right?
Yes.
Along with the documents pertinent to the McLean Hospital where she had been discharged from, right?
Yes.
Along with another notebook that had postpartum depression and anxiety, correct?
Yes.
There were also other documents that were items, I should say, that were seized in the house that have already been introduced to the record. Exhibit 81, and looks like a diary. Exhibit 83, I slept well last night, things of that nature. That was seized as well, right?
I believe so, yes.
Okay. Do you know why all these were seized?
Why the books that I seized were seized?
No. Your investigation. Are you a lieutenant, a sergeant?
I'm a captain, sir.
Captain?
Yes, sir.
And back then, what was it? You were a captain?
I was a lieutenant at that time.
You were the ranking officer in the search?
No, there was also a detective lieutenant assigned unit commander at that time.
So, but you're up there enough and you knew from the investigation what was relevant and material in the investigation, right?
Yes.
And obviously you or somebody else working with you determined that all of these items, the pills that were seized, the books that were seized from the kitchen, et cetera, were relevant and material, correct?
Yes.
Do you know who searched the bedroom? I know you said you were in there. Did you search the bedroom?
I was part of the team that searched the bedroom. There were a number of other officers that searched the bedroom as well. I believe in the report it documents who seized what from the bedroom.
Okay.
So I don't know off the top of my head who that was, sir, but I know it's clearly labeled in the report.
Okay. Do you have the report?
I do not, no.
Do you recall how many law officers were actually involved in that little bedroom searching?
I would have to guess approximately 5.
5? And as counsel asked, when somebody discovered something that appeared to be relevant or material, they would log it in. Somebody that would kind of be the record keeper would log it in, correct?
Yes.
Is there any, one of the things that you would also, you yourself, I believe, seize would be the laptop computers that were downstairs in the office, right?
Yes.
And you seized also, collectively you, I mean you or the other 5 people, seized the cell phone that was on the bed.
Yes, I believe there was a cell phone seized from the bedroom.
So it made sense as an investigator that electronic media and things of that nature would be important, correct?
Yes.
Was there an Apple Watch involved in this investigation, if you know?
I believe there was an Apple Watch recovered after the fact. We didn't recover at the search warrant, if I recall correctly.
Do you know when it was recovered?
I don't know exactly off the top of my head, no, sir.
The Apple Watch that I recovered with Pat Clancy?
I believe so, sir. Yeah, I believe there was a watch that was turned into us after the fact that wasn't recovered during the search warrant.
So looking at this drawer, do you recall that next to the bed or in the bedroom there was a nightstand and there was a drawer? And inside the drawer were a bunch of pill bottles, an Apple Watch, sleeping aids, things of that nature?
I didn't search that drawer, sir.
Okay. I don't mean to embarrass you. I'm just asking.
Yeah.
Do you know why nobody bothered to search that drawer?
I don't know that it wasn't searched. I just know that I didn't search it, sir. So it may have been searched, and maybe whoever searched it didn't feel that that information was pertinent to seize. I can't speak for them, but I can tell you that I didn't search that drawer.
Okay. Go ahead, Judge.
Redirect.
No, Your Honor.
All right, thank you, sir.
Thank you, Your Honor.
The Commonwealth would call Cory Melo as its next witness.
clerk, please.
Good afternoon. You solemnly swear that the testimony you have given to the court manager and will be not found between the common law. I shall give it to you.
Good afternoon, sir.
Good afternoon, Your Honor.
Bring Buckingham, please.
Thank you. Good afternoon. Could you please tell the jurors your first and last name?
Cory Melo,
And can you spell your first name for the record?
Cory
And your last name.
Melo.
And how are you employed?
I work for the state police.
In what unit or what's your current assignment with the state police?
Currently, I work for the commercial vehicle enforcement section.
Going back to January of 2023, what was your assignment then?
I work for the Plymouth County District Attorney's Office at that time.
With the state police detective unit?
Correct, yes.
And I'm going to draw your attention to January 24th, 2023. Were you involved in the investigation into the incident that occurred at 47 Summer Street in Duxbury on January 24th?
Yes, I was.
And fair to say that when state police got involved in that investigation, a large group of the state police detective unit went out to Duxbury to work that investigation.
Correct.
Were you the case officer in that case?
I was not the case officer.
Your role in that case, was that to assist in things like search warrants, neighborhood canvasses, interviewing of witnesses?
Correct, yes.
And in this particular investigation, you're aware that there was a search warrant executed at 47 Summer Street after the incident had occurred, correct?
Correct.
And as part of the search warrant execution, were you involved in searching the home?
Yes, I was.
And did you search the various floors of the home, meaning the basement, that first floor, and the second floor?
Yes.
In searching that home, there were a number of other detectives and troopers also searching, correct?
Correct.
Do you recall locating a phone in the upstairs bedroom, a laptop, some workout bands in the basement that were hanging on the door?
Yes, I do.
And when you recovered these particular items or located these items, did you then turn them into an evidence officer or direct an evidence officer to things that you thought might have some evidentiary value?
Yes.
At some point after the search warrant was over, you're aware a lot of items were brought back for further examination, correct?
Correct.
Is that common that when you're working on a search warrant, things are kind of... Mm-hmm.
It's okay.
You all right?
Is it common that a lot of times a search warrant, things are collected and brought back for further examination?
Yes.
Is that because it's kind of chaotic there and can't really examine things thoroughly on scene?
That's correct, yes.
So in this particular circumstance, were you asked to review some books and journals?
Yes, I was.
And I'm just going to... If I may approach the witness.
Sure.
I'm just showing you an item. Is that familiar to you?
Yes, it is.
You didn't locate this that night, did you?
No, I did not.
But you had the opportunity to review the contents of it at a later date?
Correct.
I would move to admit this crime journal.
No objection.
All right, that may be admitted. Counsel, can I see you sidebar just for a second? All right, Commonwealth?
Thank you. Trooper Melo, just in relation to now what's been marked as Exhibit 151, the Brown Journal, and just noting that when the journal opens to the first page, there's no dates on it, correct?
Correct.
And in those first few pages, just highlighting page 1, you reviewed these handwritten entries, and at some point in this paragraph, it says, obsessed with his sleep and nap schedule like to the minute. It says, hearing him cry for 1+ hours and not intervening just about killed me. I even said the words, I want to die to Pat while he was crying. After that, I became obsessed with his sleep and nap schedule like to the minute. That's one of the entries you reviewed and
Correct.
noted.
Yes.
Page 2 says, I also feel like I did it wrong because I did it when he was overtired, so it made it harder. Now I have horrible insomnia and anxiety. You recall reviewing that in the journal?
Correct, yes.
Page 4 of the journal says, why else I feel guilty? He's not really hitting his milestones. Again, that's a page that's not dated in this journal, correct?
Correct.
Page 8. I'm completely overwhelmed trying to take care of the 3 kids. I feel like I'm drowning every day. Again, another page that's not dated.
Correct.
At some point, there are some dated pages in this journal, fair to say, right?
Yes.
And there's one on November 18th. And November 18th, that page reads, it's like I'm so desperate to get a mental break from taking care of everyone that my mind is trying to make something physically wrong with me. You recall reviewing that in the journal?
Yes.
Now, in addition to the Brown Journal, when you were back at the office, you also had the occasion to review some of the other journals collected, right?
Correct.
This journal I'm holding up, exhibit number 147, is that familiar to you?
Yes.
And again, this is a journal that has handwritten notes in it, very similar to the handwriting in the Brown Journal you reviewed?
Yes.
And fair to say, the entries in this notebook only span a few pages and only go from October 13th as the first entry and the last one being January 18th, correct?
Correct.
Okay. And this third journal that you reviewed after the search warrant, exhibit number 50, the yellow journal with Callan Clancy's name on it. You recall that?
Yes, I do.
And you are aware Callan Clancy was one of the children?
Yes.
Okay. And in this instance, did you see similar handwriting from the other 2 journals that you reviewed?
Yes, I believe there was 2 separate.
Okay. At some point in this, these entries, you began to notice there were other handwriting.
Correct.
At the time you were looking at this, did you know who the other handwriting was?
At the time,
or
no.
Who it belonged to? Okay. And fair to say, reviewing the contents of it, it's a pretty detailed list of a schedule for the baby.
Correct.
I have nothing further.
All right. Mr. Reddington.
So one of the things that the district attorney did was read to you certain entries from what is referred to in your report as the Tree of Life Artisan Journal, correct?
Correct.
And when you refer in the report to the Tree of Life Artisan Journal, is that this here? What do you call a tree of life? Is there a diagram or a picture of a tree on it?
Should have a tree on it, yes.
But in any event, you would recall that that particular diary or notebook set forth on a number of pages her feelings dealing with her children. Is that fair?
It's fair to say, yes, sir.
And you wrote in your report on page 19 of 63, counsel asked you first about her stating that she had horrible PTSD from sleep training Callan, hearing him cry for 1 hour plus and not intervening just about killed me. I even said the words, I want to die to Pat while he was crying. He would be the baby, right?
Correct.
And this is her saying that not being able to go to her child because they were trying to do sleep training. She indicated that it was just about killing her, correct?
That's what was stated, yes.
And after that, I, meaning Lindsay, became obsessed with his sleep and nap schedule. Like to the minute, I would tell Laney, and you know who Laney is, right?
Yes.
Who's Laney?
The other child.
The what?
I'm sorry again, what's this?
Laney.
Laney?
Laney. L-A-N-E-Y, Laney.
Don't recall this time.
Do you recall that she had a young lady, or they had a young lady that was in their home helping with the baby while she was supposed to?
I don't recall this time.
Okay. That she would tell Laney to put him down at 10:36. I would also drive him around for car naps for hours every day, feeling guilty for doing this to my baby. Do you recall making that notation?
Yes.
I also feel guilty we did it too young, parenthesis, 1 week shy of 4 months, end parenthesis, right?
Correct.
You also noted in your report that I also, quote, I also feel like I did it wrong because I did it when he was overtired, so I made it harder. I now have horrible insomnia and anxiety, which is causing depression. I have no appetite. I don't know what's wrong with me. I want help. I want to be well. You saw that in there, didn't you?
Yes.
And then she went on and said, I think the anxiety started after sleep training. Doctor said it was okay to let him cry. I need to get a good night's sleep and take care of him, rocking him to sleep every nap in bed in the middle of the night. She noted that, right?
Yes.
Noting further in separate occasion, he's still a very happy baby despite his sleep training. Why I feel guilty is not really hitting his milestones, not rolling over, although he almost is, exclamation point. And he's babbling, which is a new milestone. She wrote that, right?
Correct.
She wrote, I have crazy brain fog. I feel like I can't make a plan. I can't carry it out. Like I just live moment to moment, waiting for the next nap time. I'm terrified of Cal getting overtired now because I feel I can't help him. She wrote that, right?
Correct.
She then wrote, I'm really worried about going back to work and not being able to function with the brain fog. I feel like I should start with a 4-hour shift and see how I do. I can't tell if I am withdrawing from Ativan and Benadryl, or is this my new baseline? I feel completely disconnected with my baby. I feel like I'm going through the motions every day. She wrote that, right?
Correct.
And there were a number of other entries that you put in your police report about that. One of which was that I feel horribly guilty about my marriage. I want to connect with Pat again. I know he needs it. I need it. I'm terrified because I'm terrified of the relationship. She needs to get birth control first. She made reference to her inability to have conjugal relations with her husband, right?
I believe so.
She indicated further on into her travels, I am completely overwhelmed trying to take care of the kids. I'm drowning every day. I feel guilty that I'm spending my family's money and not making any. I feel like I spend way too much. She wrote that, right?
Correct.
I'm terrified of Callan getting sick. He's a sick baby. A sick baby is miserable. He's sick now with a double ear infection. Clearly has a bellyache. It's miserable. I feel like the other kids are going to get him sick all winter long. She wrote that, right?
Correct.
I always feel strongly against sleep training. I feel like it's abusive to let the baby cry and not respond, but I made the decision. I did it with Cal. It is way too much crying. It's incredibly stressful. She wrote that, right?
Correct.
He's okay. He will be okay. It's not harmful in any way. The doctor said it was okay. Plenty of people sleep train their kids at that age. It's necessary as a third child, is what she wrote, right?
Correct.
I feel incredibly sad and guilty about not breastfeeding anymore. That was the one thing I could do to help his immune system, and I can tell he really doesn't like the formula. I'm very sad about this. I know at this time it's what I needed to do for my mental health. She wrote that, right?
Correct.
And then the statement started getting smaller and smaller as time went by. One occasion, it's like I'm desperate to get a mental break from taking care of everyone. My mind is trying to make something physically wrong with me. My mind never shuts off. It's constantly thinking of the next thing someone needs. I can't shut it off. I desperately want to go back to work, but now I don't know how I'm going to function, and it worries me. Wrote that, right?
Correct.
There were 2 pages that were blank that she didn't even write on. And then on the third entry, affirmations. She wrote affirmations. On November 22nd of 2022, I am calm. I will remain calm today. There is nothing that needs to be on my mind. The weight is lifted from my mind. I will sleep tonight. She wrote that, right?
Correct.
Continuing on into November, I slept well last night. I will sleep again tonight. Today will be a great day. I will go back to work on Sunday. I will thrive. I can feel like myself again. That was November 23rd. She wrote that, right?
I believe that's the day, yes.
Gratitude. I'm grateful for Sue, who's always listening. That'd be a mother-in-law. You knew that, right?
Yes.
Sue, I'm grateful to Sue for always listening and trying her best to help me. Kids are sleeping great for Pat. Pat is handling nighttime stuff. Julie for making a plan for me. A big thing is I feel disconnected with myself. Time, reality. I think going back to work will help with that. She wrote that, right?
Correct.
And then there are numbers of pages, 22 of 63, 24, 25, 26, 27, 28, all reproducing what counsel asked you about and what I just went through that were from those journals, right?
Correct.
Did you have anything to do with the search of the house?
Yes.
Did you search in the bedroom?
Yes.
How many other people were with you searching in the bedroom?
I don't recall how many other people were with me at the time.
You know why nobody looked in the drawer and found pills and sleep aids and Apple Watches?
I'm not aware.
Did you see the drawer?
I don't recall.
What?
I don't recall.
Okay. That's all I have, Judge.
Right. Redirect.
Nothing further. Thank you.
All right, thank you, sir. You may step down. Counsel, could I see you at sidebar? All right. So, members of the jury, we're going to break at this point till tomorrow. All right, and talking to counsel. My expectation is we'd have a similar schedule tomorrow. The hope would be we'll go in the morning and should go into the afternoon. But just to give you that's the best estimate that we have. All right, and so I'm going to excuse you till tomorrow. Remember, I'm going to ask you those questions. Don't listen to anything. Don't talk about this. Don't take any road trips or do any research on this. Put this out of your head as best you can until tomorrow morning. Hopefully the rain has stopped, and we'll see everybody tomorrow. Thank you so much for all your work here today. Thank you.
Order. All rise. Jurors, please close your notebooks, place them on your chairs. Follow me.
All right, so we'll be in recess on this until tomorrow morning at 9. Thank you.
Thank you.
Thank you.